One of the great things about this event is everyone's greeting each other and seeing old friends and colleagues from across the state, which is exactly what we had in mind. Hello, I'm Andrew Dreyfus from Blue Cross Blue Shield of Massachusetts, one of the co-founders of the Mass Coalition for Serious Illness Care, along with the Conversation Project and Ariadne Labs. It's my pleasure to welcome all of you to our second annual, and I underline annual, summit. It's good, especially for me, to be here in Massachusetts because my work has taken me quite frequently to Washington over the last few months, where it remains divisive, partisan, and particularly disconnected from the needs of patients and their families. In contrast, here in Massachusetts, we repeatedly unite around a common purpose with a shared set of values and a vision to make healthcare better for everyone in our state. And it was in that spirit last year that we came together to start something new and different on serious illness and care at the end of life. Of course, we weren't starting from scratch. We were building on years, decades even, of work on this issue in Massachusetts, and many of you in the room were building on this foundation for those decades. But it felt different here last year in this room. It felt like we were in a new time, with new possibilities and a collective sense of opportunity. Today we're here to mark our progress over the past year, and you'll be hearing much about that throughout the day. But we're also here to understand better the distance we still have to travel. Let me tell you a very brief story that kind of encapsulates that challenge. Recently, a close friend called me for advice. Her father had stage 4 cancer and was clearly approaching the end of his life. The family was confused about what to do next, what choices to be made, how to provide the best care for their father. I suggested they ask for a palliative care consult to make sure all his medical and emotional needs were being met and they were being cared for in one of our superb academic hospitals here in Boston. When they asked the question, the response was, "Oh, so you want to give up?" This experience, familiar I'm sure to many of you in the room, is just simply unacceptable. For that family, for all our families, it's our job collectively to change that story, to make sure that everyone has the opportunity to express their wishes and values, and that the healthcare system meets and respects those wishes and values. The great thing is this problem can be fixed. You know, we've tackled these big, complicated healthcare problems in Massachusetts before in ways that have set examples for the nation. In this case, fortunately, I think I may have said this last year, we don't need a bill in Congress or even on Beacon Hill, though surely there may be a time where we need policy to help support our efforts. But we believe this problem can be solved with us, with our work, but it's not going to be easy. We all have competing priorities. We have resource limitations. I mean, I'm just always amazed on a typical primary care visit what that PCP needs to assess, the medical needs, the behavioral needs, the social needs, and also get the diagnosis right. When we're at home, there's always something more pressing and less daunting than we could talk about over dinner with our families than our wishes at the end of life. But most importantly, the challenge is our healthcare system, by its very nature, tends to resist change. So while our efforts may take years, we must move with focus and with urgency. And we must think systematically. We must create sustainable change that will last beyond the tenure of one champion in one hospital or one nursing home or one home health agency. We have to make these conversations easy, make them the default, the standard of care, and the cultural expectation in all the myriad different ways we all in this room touch the citizens of the Commonwealth. What's exciting is how much we've accomplished so far, and I'm struck by what I see in this room and what we've been seeing all year long. For starters, we've grown. Last year, we launched this coalition with 58 organizations. This year, we've grown to 79. And I'm convinced that some organization in this room that's not yet represented is going to sign up today and put us over 80. We're seeing increasing activity in every corner of the state, from healthcare organizations and the faith community to state agencies and health plans. We saw an especially exciting burst of activity during the month of April, our month-long Healthcare Decisions campaign. We saw coalition member Facebook and Twitter pages light up with campaign calls to action. We saw countless internal and public-facing newsletters flooded with messages about advanced care planning with links to tools and resources. Others went even further, hosted dedicated trainings for clinical staff and community events for the public. And thanks to Beth Israel Deaconess Medical Center, advanced care planning even made an appearance at Fenway Park. We've also seen growing collaborations among coalition members. For example, leadership from the Bethel AME Church joined together with researchers from Ariadne Labs to train faith leaders using an adapted version of Ariadne's Serious Illness Conversation Guide. April was a big month of Blue Cross, too, packed with events, offerings, communications for our employees, including lots of opportunities to earn wellness program points, which you can get at Blue Cross by participating in advanced care planning activities. We shared the results of our first ever employee survey on this issue with nearly 2,000 of our employees responded to, helping us to better understand how they wanted to engage in advanced care planning. We hosted on-site trainings with honoring choices at all our locations. We had cafeteria demos with cake. No, cake isn't something you eat in this case. It's an online advanced care planning tool and our newest technology partner. We also offered free lunches to those who wanted to learn about our broader work on serious illness. But it wasn't just April, of course. For example, at the policy level, the Massachusetts Health Policy Commission, and I see that its Executive Director David Seltz is here, published its report on serious illness and end-of-life care in the Commonwealth, bringing greater understanding and awareness to this issue. From Cape Cod Healthcare's growing army of advanced care planning facilitators, to the Conversation Project's statewide collaborative, to the Boston Bar Association's healthcare proxy brown bag lunch, from the Archdiocese of Boston's sold-out palliative care colloquium, to UMass Memorial's work standardizing how advanced care directive forms are stored in the electronic health record. Across the state, we're seeing so many organizations take up the challenge of the Coalition's goals in new and exciting ways. We're especially excited, and you may have read about this today in the Boston Globe, that the Coalition is bringing together leaders from all the Massachusetts medical schools to talk about core curriculum in palliative care and advanced care planning communication skills for students. And you'll hear more about that and all this other work this afternoon. So let me tell you a little bit more about our day. As ever, we're incredibly important to have our co-chairs, Atul Gawande and Maureen Bisognano, to lead us today and as they do throughout the year as our co-chairs. Later this morning, Atul will tell us more about this year's consumer research, a deeper dive into the experiences and reactions of those engaging in advanced care planning. In the afternoon, Maureen will moderate our interactive sharing session where we'll get to hear from all of you and the work you're doing. And throughout the program, Ellen Goodman will be sharing with us several videos featuring stories of real people in Massachusetts and their experience with serious illness and advanced care planning. Before I go on and before we begin the formal program, I just want to take a moment to thank some important people who have made this day possible. Harriet Warshaw of the Conversation Project, Megan McLean of Ariadne Labs, and Anna Gosline of Blue Cross Blue Shield of Massachusetts, and of course, who many of you have met, Richard Averbush, the Coalition's Executive Director. Richard took over the day-to-day running the Coalition during Anna's infamous maternity leave, and he quickly became so indispensable, we knew we had to keep him. This day would not have been possible, Richard, without your extraordinary efforts. And now it's my pleasure to introduce one of my own heroes in this movement, Alice Bonner, the Secretary of Elder Affairs. Of course, we're a little disappointed that our Governor, Charlie Baker, couldn't be here with us today. He wanted to be, and unfortunately he's attending a funeral, which is probably a useful reminder that these issues are never far away from touching each and every one of us. But there's no one better to reflect on these issues and how our state can be a partner to advance our shared goals than Secretary Bonner. She and her team have been the central driving force behind the administration's engagement on advanced care planning. She is literally everywhere. I think there may be 5 of her. They've achieved such an impressive amount in such a short period of time, so please join me in welcoming Alice Bonner.
that I've been everywhere, but it does feel like it's been sort of busy. So anyway, it is wonderful to be here, and again, Governor Baker is very disappointed that he cannot be here with us today. But if you were here last year and you heard him speak from the heart about how personally he is committed to this issue, you know, his energy, his passion for this has not waned. So that is the message that I bring to you from him, and you're going to be hearing about all of the support for the work throughout the state that I'm going to talk about this morning. I did want to start, though, by reflecting on some of my other roles. So I know I talked last year about being a family caregiver, which so many of you are as well, but also my role as a clinician. So I started out as a nurse practitioner. I graduated in 1989, and I thought I finally had, as a nurse, I thought I finally had all the tools of the trade that I needed for the older people that I took care of to really do a great job. I had, you know, I had my stethoscope, you know, you wouldn't leave the home without it, it just becomes sort of part of your body like this. I had my new prescription pad, I could write prescriptions now, which of course with older people I learned to use as little as possible. And, you know, I had my pager, and you feel naked if you walk out of the house without any of these things. So you think you're ready. And I found myself, I was doing post-acute care, so on the weekends, the nurse practitioners would cover, and we'd cover like 20 nursing homes, and there would be admissions from the hospital. People who were really, really sick. Not only older adults, but people who had multiple chronic conditions, acute conditions. And invariably, I'd walk into a room to do an admission and begin speaking to someone, and I would say, has anyone spoken to you about your, you know, what you want out of being here, about your goals of care? And it was just amazing to me after engaging in this conversation, how many people said to me, no one has ever asked me those questions. No one had ever asked them. Not the primary care doc, not the oncologist or the cardiologist, not their family or their best friends. Just it had not, that conversation had not happened. So I really think that, you know, when you go into someone's room and you're in that position, you have to build trust so quickly. You don't have a relationship with them. I've never met this person before. And now I'm the one who's trying to have this really, really important conversation. So I think it made me realize that the tools of the trade that we need as clinicians are learning how to have these conversations and then practicing those skills. And again, a lot of the work through Ariadne Labs is about practicing these skills. They're not really, really hard, but you can't do it without learning and really attending to practicing them. The other thing that I think it really drove me toward was the desire to look at policy so that we collectively are looking at getting involved earlier before there is a crisis, and someone like me without a relationship with someone is in that position of trying to help identify and honor and document and carry through on someone's really, important wishes and goals. So that's the framework that I bring to this work as a clinician and to this policy work. But you came to hear me talk about all the things we've been doing in state government. So let me turn to that because we have been really, really busy, and there's a number of people here that I'm going to recognize as well. And, you know, we've been working hard in a couple of ways, one of which is to start with, I would say, putting our own house in order, you know, becoming a model employer as the state. We are, as you know, a very large employer in the state. And so looking across EOHHS agencies. And we took this approach that if people, as our employees, are looking out for themselves first, that those of us that work with consumers and patients and other people throughout the state whom we serve will be in a better position to do that. So to start, led by Secretary Mary Lou Sutters, she, in her monthly newsletter to staff, to over 22,000 EOHHS employees, sent out information about Healthcare Decisions Month, connecting people with resources, honoring choices, the Conversation Project. Think about this for yourself. Think about this for your patients and the people you serve, et cetera. So that was really how we got started. At the Executive Office of Elder Affairs, we serve 1.2 million people, older adults throughout the Commonwealth, and we've continued work that actually started even before our event here last year. So Mary DeRue, where are you? Mary, stand up so that we can recognize your work. So Mary, who is our Director of Home Care, along with Al Norman and the Mass Home Care Group, a number of our Aging Service Access Point executive directors are here today. They began by something called the Mass Home Care Health Proxy Challenge, and they encouraged all board members and staff members of our Aging Service Access Points to do a number of things. First, to listen to an online seminar on making a personal care plan. 40% of the roughly 3,200 people did that. We asked them to name a healthcare agent. About 25% did so. We asked them to complete a healthcare proxy form and give it to their doctor. About 19% did that. And then we asked them to have a conversation with their doctor about what was in their healthcare proxy and their wishes and preferences, and about 12% did that. So you can see the numbers kind of slowly drifting down. But collecting that data and doing the work that Mary and Mass Home Care did to collect that data lets us know where we stand and where we have work to do. So it's really been very valuable. And 19 out of the 26 Aging Service Access Points have been participating in this program. So we have more work to do, but so far very successful. We also looked within our own agencies. So the Executive Office of Elder Affairs, we have about 100 folks who work for us. We sent out a survey. Mary sent out a survey to our team, and we had about a 30% response rate. And just again, in our own office, about half of the people who we surveyed had not completed a healthcare proxy. And of those who did not complete a healthcare proxy, about 50% said the reason was because, quote, I'm healthy and don't need one yet. So we said, we have more work to do here. But again, good to know. And so what Mary did after that was, spearheaded an educational campaign to give people access to the resources, Conversation Project, Honoring Choices, and others, because if people understand that for themselves, our workforce and our teams are in home care. They're out with consumers in their homes, nurses, case managers, so it really becomes a part of what they do and a part of our being a model employer. So let me move on. Where's Jody? Jody Hsu, stand up, please. Jody has been, I would imagine almost everyone in this room might have heard from Jody at some point during the last year. She's been very, very busy, but in particular with our state agency colleagues. She has worked with the Department of Public Health, the Commission for the Blind, and the Commission for the Deaf and Hard of Hearing, and in all of those cases have been providing resources, information. In the case of the Commission for the Blind and the Deaf and Hard of Hearing, they have done surveys of their own teams, similar to what we did in Elder Affairs. Again, putting resources in the hands of the folks who are working with constituents every day. We've been in conversations with the Group Insurance Commission and Dr. Roberta Herman, and this is their busy time because of open enrollment, but we'll be getting back in touch with them about moving forward on some next steps as well. I think folks are here from the Department of Public Health. Lindsay, Associate Commissioner Lindsay Tucker, are you here? Stand up, please. And Daryl Villaroos in the back of the room, I know, is here. Stand up, please. In addition to the work with the local and regional offices of the Department of Public Health, to increase awareness of Healthcare Decisions Month, the COO of DPH sent out communication to the 2,900 DPH employees, and Commissioner Burrell also sent out in her newsletter a highlight about Healthcare Decisions Month. In addition, we've talked to the Mass Association of Public Health Nurses, the Mass Association of Health Boards, the Board of Nursing. I know Maureen and I spoke there. And DPH, I know Daryl and the team is working on our state MOLST form, medical orders for life-sustaining treatment, and to align better with the national POLST form and the POLST paradigm. So again, all very important work. So that's a lot of work within our state agencies, but we didn't stop there. So somehow, I don't even remember how this started, Jody and I got connected with the libraries. I think I thought of it because my father was a librarian, and I thought, libraries, nobody thinks about libraries anymore. Let's see what we can do. So we connected with the Mass Board of Library Commissioners, and they were unbelievably excited about spreading the word, because I think they feel maybe that people don't consider libraries, and they are, in our communities, a fantastic way of sharing information. A lot of people still use libraries, and so they sent out multiple communications. They educated the librarians. Here's how you can get information about this. It was really very exciting, and we just kept working with them because they were so enthusiastic and so much fun and did such great stuff. Vivian Pham, do you want to stand up, please, for your work? Vivian works in Secretary Sutter's office, and she took it upon herself to look into some innovative arts programming. So arts and humanities, let's not forget about that and how critical that could be in this work. So there's a program called Before I Die. You may have seen these Before I Die walls, and it's been implemented around the state to promote Healthcare Decisions Month. She partnered with South Boston Youth Programs and Art Week Boston at the Boston Center for the Arts. And, you know, we all know that we want to be data-driven. That's a given in this day and age, but data alone is not going to change, you know, public perception about this issue. We have to have compelling stories. We know that too. So arts and humanities and work like Before I Die is so critical to getting these compelling stories out there and really moving people to action. So I know that's just a start, but we have really tried to touch a lot of these different points, not only within state government, but also connecting outside of state government as well. And the final area I want to talk about, which certainly the governor would have spent some time sharing with you, is around digital health and the opportunity right now, particularly because we are Massachusetts and we have so much technology and innovation and digital health going on here, the opportunity to bring the issue of advanced care planning from paper and pencil to the digital arena. And so right now, again, many people here certainly know that this is a paper and pencil process. It's something that's done at people's kitchen tables or at your law office, your lawyer's office. And even if it gets into the electronic medical record at your institution, maybe it doesn't cross to another place where you happen to be. And even if it is in your electronic medical record, if you wind up in the emergency department, it might be buried somewhere under tabs and pages, and it can't be pulled out easily. So we know there's issues there. We also know people are not always in a hospital. So even if it's in the hospital, if you are a first responder or a public safety person and you really need access to that advanced directive, you may not be able to get at it. And in addition to that, there's been some questions raised about the validity of the, you pull out somebody's advanced care plan and, you don't really know for sure, is it valid, or there's a smudged signature, and there's a lot of rules that need to be followed. So moving from paper and pencil to digital health is going to be really important for this. And Anna Goslin, if you want to stand up, and I don't know if Lawrence Stuntz or Judy, Lawrence is here. These guys are leading work. This is work along with the administration and the Massachusetts Digital Health Initiative. So whether it's going to be through MIHI or another venue, moving to electronic advanced care planning that can be cloud-based so anyone can access it at any time is really the goal. And again, I think there's going to be some really exciting work in the upcoming year. So in wrapping up, I think, again, I want to, on behalf of the governor, I want to thank everyone here in this room, and certainly leveraging the talent and the energy and the expertise here. I believe that we are going to be able to certainly honor people's wishes and preferences and goals of care even more than what we're all trying to do now. So the last tools of the trade that I will mention is I'm a nurse, so I am never far from Florence Nightingale. And this is Notes on Nursing. It was first published in 1859. And the funny thing is, a lot of what Florence talked about and a lot of her quotes still resonate. And so one of her most timeless quotes is this, Quote, "I attribute my success to this. I never gave or took any excuse." So when I look out into this room and I think of all the work that's happened in this last year and all the work that's going to happen going forward, I see a room full of people who will not give or take any excuse. We know there's barriers. We know this is going to be hard. We know it's going to take us years to move the needle. But I just think that next year we will be standing here after another year, and advanced care planning in Massachusetts will have moved forward even farther. And so I think this has been a great year so far, and Andrew, we got this. Thank you.
My mom was a very phenomenal person, hardworking woman. She grew up in Puerto Rico. She came to the United States, and she ended up working in, the sweatshops of New York. That's how she made a living. But she was a great seamstress. She would sew clothes for me. She would have matching mother and daughter clothes, which nowadays would be like, ugh. My mom had had cancer, I believe it was in 2014, and she came and stayed with me for a period of time. And we had thought that the chemotherapy had actually affected her memory. It turned out that she actually had Alzheimer's, and so she ended up living with me for a period of time. I took care of her as best I could for several years, pretty much full time. And it ended up that we couldn't take care of her anymore due to safety concerns and safety issues. My mom had always explained to us about her desires. She really didn't want to go to a nursing home, which I can't blame her. I certainly wouldn't want that either, although the nursing home that she went to, they gave her wonderful care. And she had said that she wanted certain quality of life. I think it's really important to understand what quality of life means because it's very different for different people. And some can articulate very clearly what quality of life would mean to them, and some clearly can't. I do find that the more conversations there are with regards to each step of the process helps a little bit because then everybody feels like they're part of that process. There are some levels of control that they have. What I tried to do right from the beginning with my siblings is to engage them in whatever care she needed. So even though I had the healthcare proxy, I wanted them to be part of that decision-making process. I think for my younger brother, it was a little bit harder, and I just would talk with him and just listen as best I could, and then also bring him back to what would Mom have wanted. I've had conversations with my kids about quality of life. They know how I live my life and how I would want to live my life, and so that they understand this may be very difficult, but this is what I would like. The importance of the work that the coalition is doing, I think that the more involvement and the more training that medical personnel have, the easier these transitions can be made for families. And I think that the more information gets out there, the more support that can be given to families, I think the process could be made a lot easier and less painfully for those who are survivors.
Hi, I'm Atul Gawande. I'm a co-chair with Maureen Bisignano of the Coalition and a grateful partner with Andrew Dreyfus, who's been a co-founder with us of this whole effort, as well as Ellen Goodman from the Conversation Project. So, and I thank you for coming today for the second annual meeting. One of the core things I want to say is reflected in what Lillian had to say. She was one of the people who we surveyed last year and agreed to let us contact her. And we contacted people, and they had the most extraordinary stories. But I just want to point out Lillian, who's here today, if you don't mind standing up. Their experiences are exactly what this is all about. We set a very high bar in this work. We began by polling people about what the conditions of the care we're providing for people as they come to the end of life really are. And it was not a pretty picture last year. We understood that that is our mark, how much we actually change the experience for people as they go along. And that means that all of the activity that we're all beginning to engage in, and many have been engaged in for a long time, has to add up, has to come together to be something meaningful. And the goal was really built around a fairly simple, fundamental idea. People who have serious life-limiting illness or serious frailties have priorities and goals for their care besides just survival. We have aims for the quality of our life as well as for the quantity of our life. The most reliable way to learn what those aims are, what those priorities and goals are, is to ask people. But we don't ask. We ask less than a third of the time. When we do not ask, the result is suffering. And that's what these stories help us understand, how the suffering translates. The suffering can be people receiving more care than they wanted. It can be less care than they wanted, or it can be the wrong care in the wrong way, not respecting what they really are hoping for as they go through life's journey. Lillian's lesson was really simple. So if we are not asking, let's ask. And it brings across how complicated it is. It's Lillian being able to connect with her mother about those questions, and then the brother who, had a harder time getting there. And then it also is about the caregivers coming in along the way. Lillian's lesson about asking and how important it is backed up by our survey data as well. So this year, we contacted all of those people who agreed to let us contact them in a follow-up and did a survey to find out some deeper information and to understand a little bit about where we are. One of the things that came through in the survey is how strongly people feel that that this is an important issue because the experience of having someone die who is close to them is much more widespread than I think we quite realize. We have 39% of participants in the survey who'd had a loved one die in the past couple of years, with about half having happened in the last year. This is something that therefore touches constantly people we know. Second, they believe that that it's essential, it's important for people to have conversations with their loved ones and with their healthcare providers about their wishes for their care. The numbers here are stunning. 96% voicing that this was important. It is effectively 100% given the margin of error in these conversations, that these conversations are vital. There's differences of opinion about what people want for their care. A lot of people, it's about 80%, have a level of the quality of their life that they would not want to continue to be kept alive if you dip below that level of quality of life. But it's also vitally important to understand that 14% want caregivers to do whatever it takes to keep them alive regardless. And honoring people's wishes means understanding which is the person you are. And also where that line for quality of life for you is. And we perfectly well understand that that changes over time and with experience. And so this is an ongoing conversation as people go through their experiences in life, learn what they turn out to be able to adapt to, turn out to be able to tolerate that they never thought they could have, that the meaning that they can have in the face of serious illness and frailty that can be discovered, while also recognizing the points at which people feel they simply are not living the life that, living the quality of life that they would find acceptable. People have great fear of these conversations. The majority of participants let us know that they thought these conversations around planning your goals for end-of-life care are harder than having conversations or making plans about how to distribute their money after at the end of life. So 71% thought this was harder than planning for how their money might be distributed after death. And yet, this is a complicated slide. I'd first point out that what it shows is that among all people, the vast majority found that when they've had the conversations, they didn't turn out to be as difficult as they thought they were going to be. Even more, when they were had some form of resource, whether it was a toolkit from the Conversation Project, guidance from a counselor, the support of a lawyer or a clergy, someone who will offer advice and support, a resource for thinking it might be their provider, it helped them have that conversation more effectively. Could be simply a book, a film, a other kind of resource, but 80% with the help of that research found that the conversation was not so difficult after all. And even when they didn't have that research, that resource, broaching it still in that group, they found that 65% still found it to be less difficult than they thought it was going to be. I point this out because many of you are providing these resources, and this is real data showing how much of a difference it can make. That people find it to be helpful. It makes it so that they are clearer about the goals that they're trying to achieve in these conversations. There's a core mistake that people make, which is that this is about a conversation about whether you're going to fight or you're going to give up. That classic thing that Andrew mentioned about, a healthcare provider who still saw it that way. And this is not a conversation about whether you're going to fight or whether you're going to give up. This is a conversation about what you're fighting for. Are you fighting for your best possible day today? Or are you fighting to sacrifice some quality of life now for the possibility of time in the future? People have different answers to those, but it really is about how you have control and you get to name what you are really fighting for and what you want the caregivers to be fighting for you along the way. And I think the resources are crucial to helping people navigate that understanding. This is information about how far we still have to go. This is again another complicated slide, but I will pull it apart for you. First of all, it makes a huge difference when people have this conversation. What you see on the left is the extent to which a healthcare team talked to a loved one about their wishes. When there was no discussion, 70% found that the wishes of a person were not honored at all. 70%. When the healthcare team talked to a loved one about their wishes, 83% found the wishes were honored. And it makes a difference when you've talked to a family or friend as a separate matter. So when you have talked to a family or friend, not necessarily the caregiver, but when you've talked to a family or friend, then 77% of the time people feel their wishes were honored. Whereas it goes down to only 30% if they had not had that conversation. This is both how simple it is, how powerful it is, and how difficult. The further indictment of where we are is that, in general, about a half of the people we surveyed who'd experienced a loved one die in the state of Massachusetts found that the care was ranged from poor to fair to good. 50% thought it was very good to excellent, 50% thought it was not. Those are pretty terrible ratings, and if you've ever seen satisfaction scores for hospital care, surgery, visits to the doctor, they're all in the 90%. Think it's like 90% is even not a great score when it's achieving excellent or very good. You know, the top performers are at 94, 95, 96% are at very good to excellent. So a world where half of the population generally feels that the care is not very good at the end of life is a telling indicator of how far we have to go. But it is also a telling indicator of how much these conversations make a difference in shifting those scores. So the extent to which a healthcare team talked to a loved one about their wishes, if people had not talked to the healthcare team, they were at 80% likelihood that it was only good, fair, or poor care. So it's not just whether the wishes were honored, it's just also whether the overall picture of the care was a decent care. And we're not delivering that when we're not having this conversation. But when the healthcare team talked to the loved one about their wishes, we're at 84% getting up to that level of excellent to very good. That is a transformative difference. And it is just as powerful for people to have talked to a family member or friend about their wishes, with it translating to only, when they have not, 63% finding that their care ultimately in life that they saw for their loved one was only poor to good. Goes up to 71% being excellent to very good when that conversation has happened. That is critical, I think, to understand. I'd like to show one more video here, and this time it's set at Orchard Cove, and a place where we have a group of people talking about what they're experiencing in their care and in the environment where they're aging.
We took care of all the paperwork which is necessary apparently for civilized people to leave this world.
I had done all the right things. I prepared all the legal papers, the will and the proxy and the advanced care and all of that.
I've done all the regular things, who's getting what and financially and all that. But I hadn't talked about me and what I would like.
What's important to me is living now and how I live my life, being able to be engaged with people in conversation, being able to read and process what I'm reading, being able to give back to community.
First of all, I have to tell you that I have a disabled wife. Our present primary care physician is fantastic, and he was very helpful in being open and being receptive. And perhaps, that would be really, as Mel said, that would be a very important specification for the right primary care person to be able to listen to you.
I feel very lucky because my primary care physician listens and asks questions. My concern is the specialist. What happens if I develop something that requires a specialist? I think specialists tend to be very narrow visioned and they focus on the ailment. How do I keep my primary care physician involved enough in a situation like that that we would be able to override what the specialist would be determined to do?
Orchard Cove is a place where, first of all, a meeting can take place to talk about this. And the participation was tremendous. It was a mind-stirring meeting for many people.
You're asking me what doctors should know about how we feel about the end of life? I think they should listen to what we have to say, more than in a clinical way. We're talking about end of life. You should listen to the person and see how they feel about it.
I would echo that.
Yeah, that's very obvious, yes.
Listen.
Listen. They were pretty tough on us as a profession. I'm one of those specialists. It's like, how do we avoid that guy? But legitimately tough on us. Andrew told a story of what he experienced, and I think we've all got them here. The one I had most recently is a friend of mine who came to me because his mother was advancing with ovarian cancer, was getting care at a great center here, and wanted to know what we do about being able to have, what he could do to be able to have his mother's wishes for quality of life come forward. And I said, perhaps you could get palliative care involved. And he said that the oncologist involved in the ovarian cancer care was against it and had discouraged it, and his mother did not want to go against the oncologist. There are two aspects of this that are really troubling. One is the idea that there's an opposition between the quality of life you're going for and the quantity of life. And all of the evidence is against that. All of the evidence is against that. The evidence is that the quality of life that you achieve, whether it's towards the end of life and being on hospice care where you have measurably improved life, or palliative care all the while you're going through your oncology care, is associated with significantly improved symptoms of care, reduced likelihood of depression and anxiety, earlier likelihood people stop the most aggressive forms of care, less suffering at the end of life, and equal or better survival. And so when people like the folks at Orchard Cove are saying, please listen, what they're saying is, listen to both what we're aiming for in the quantity of life and the quality of life as well. All three of our video participants are here, and I wonder if you might stand up and show your home. This is a group that is listening, and that's our promise. We have data to back up everything that they are telling you. Sorry, let's go back one. The first thing is that when people have a conversation with a healthcare provider, the majority of the time they're reporting to us that they are the ones who have to initiate the conversation. 65% are the ones who initiate the conversation. Furthermore, they often, in about a third of the instances, turn to having resources in their hands for those conversations. So again, the work you're doing to offer people support in whatever form people need to learn, visual, written, directly side by side, those are turning out to be really important resources for people along the way. The big reasons why people are initiating these conversations, number one is simply that they see it as the top priority, that they want their wishes known, or that they've seen a prior experience with friends or family members dying that had concerned them about what their care might be like. Those are the biggest reasons. They may be doing it, though, because of their own illness or surgery. because they simply thought it was time, because it came up casually as part of conversation, because it might be part of estate planning, or it was they were considering completing the set of forms that come along that we are encouraging people to fill out as they come to National Healthcare Decisions Month. So there's a lot of reasons why people might do this, many of which would touch you and your organizations. So the interesting thing is that just as people thought these conversations with their family would be difficult, people often think that these discussions with their clinicians will be exceptionally difficult. But once the conversation was underway, 76% found that the conversation with a healthcare provider was not so difficult at all. There are small surveys of providers that find a similar kind of story. Clinicians have as much anxiety about these conversations with their patients as the patients do. And that's the biggest reason why people are reluctant. The clinician, and I know it from my own conversations with my patients, the clinician is worried that initiating this conversation is a sign to the family that you're giving up on them, that you're no longer with them, that you're signaling to them that somehow things are no longer either going as well as you want them to, that you're trying to hint at some ulterior subtext. And the more that we make these the normal conversation, the easier it is for us to also overcome our anxieties. And the toolkits that we provide for providers, and the support and the learning and the capabilities and the coaching and the messages in the general public that these are conversations that people are expecting to have, these are as important for people in the provider community as it is for people in the public. It's all of us coming together that's fundamentally important. The ways in which these conversations build on good relationships or strengthen those relationships is critically important. So the major reasons people didn't find these conversations to be difficult was because it either strengthened or built on that kind of a good relationship. And also recognizing that they were motivated to have this conversation either because of concerns about death and dying or concerns about advancement of illness. Now, why would people think that it was difficult, or what experiences that they have that suggested it might be difficult? And a lot of it revolve around the same kinds of experiences, that it is a difficult topic, hard for patients to face, and that they have personal experiences with illness or death in the family that have scared them by what they saw, and then instead of leading them to want to talk about it more, can lead people to want to shut down. We can see both things happen. When physicians or nurses or others in the clinical community actually initiated the conversations, one of the great fears is that that people will react negatively to initiating that conversation, and by and large, first of all, it wasn't very many of our respondents where the providers actually initiated the conversation, so we're down to enumerating the numbers here. But when you have it, those conversations happen. There was only 3 respondents who had found it to be a negative experience. It was fine, no big thing, normal question, comfortable, was something regularly asked by the doctor, and it went well. Now, so what were the reasons why there might have been a negative experience in those handful of cases? Clinician didn't want to hear it, not happy because it was not usual doctor, irritated because the doctor was dancing around the subject. So this is all of our responsibility to build this capability. One thing that we also recognize in these is what we've come to call the full circle conversation. That is the conversation that you've had a healthcare proxy, you've had a conversation with that healthcare agent who will speak on your behalf when you can't. Or it's another family member or a loved one, but you've had a conversation with the important loved one in your life, and you've had the conversation with a clinician. And that full circle conversation was only present in 10% of the survey respondents. And that's a major sign of how far we have to go. The survey buttresses many lessons that came to us last spring. And I think it also provides some data that is going to be very encouraging, which I'll come to at the very end. We launched a year ago with an incredible sense of opportunity and of a sense of growing momentum in this state. We have, across the state, leaders who are not only driving this issue at the state level, but driving it nationally and internationally. Since last year, we have got ourselves a new president, fear about whether some fundamental American values might or might not be in doubt around whether we live for the human decency of our community, about reason, about our devotion to compassion. We are engaged in a battle over whether we are going to protect people's health care coverage or not. An ACA repeal bill passed out of the House. But we're in a state where both the Republican Party and the Democratic Party have made a bipartisan commitment that we are not going to threaten the coverage for people in this state, and that we would work together to preserve all the gains we have made. And that is the kind of extraordinary place that we are building this momentum from. There was a lot, nonetheless, moving forward even nationally, here in Massachusetts, but extending across the country. First of all, in the time since we've come here, we've seen adoption of payment for serious illness conversations, and it's entered into something that providers are now regularly using under Medicare. In June, I got to testify before the Senate about our work here in the Massachusetts Serious Illness Coalition in a meeting chaired by Susan Collins. We saw since then, we saw the passage of a Medicare final rule that many of us here in the room had advocated for, and this is a Medicare final rule for nursing homes with provisions that assure people that they can have a voice about the quality of their life and not just safety and survival. Those provisions include allowing people to have choice about privacy, control over having a say if you have a roommate, who that roommate might be, control over your schedule, such as when you go to sleep and wake up, when you eat. Those are basic rights that in most of our places is the kind of standard of what is expected and what we enable in our homes in our senior retirement communities and our nursing homes in particular. But it's by no means universal, and that's pushing us in the right direction. Furthermore, we reached a point where our private insurers are now covering hospice without giving up on curative, without your having to give up your curative care. That is a huge accomplishment, and it is setting a bar for what the rest of the country can do. We've in our group and other groups here, we've advocated for the idea that hospice should not be limited to people only when they have given up on being willing to go through chemotherapy or surgery or other kind of care. And there's copious evidence that people end up with better quality of life along the way, often choose to stop those forms of care sooner than they would otherwise, but are benefiting widely from get earlier benefit from hospice with great results for them. And that kind of approach has gotten now bipartisan support in Congress. The ultimate place we're trying to arrive at is we are a state that has built the state-of-the-art for how to help people live the longest possible life they get to have. We are providing state-of-the-art and designing state-of-the-art care for your quantity of life. But we are now also becoming the place that is designing, pioneering, pushing, advocating, creating, innovating in how we are state-of-the-art care for the quality of life that everybody gets to have. And we're demonstrating that there is nothing that divides the world between our Kendall Square biotech, incredible engine of change in the healthcare world, and this innovation and drive around the quality of life we can have. One thing I want to point out is that we've had some serious momentum that is building. You heard it item by item in what Andrew and Alice painted as what's being accomplished now in this coalition. But we also see it turn up in the survey information. If we can pull up the slides for the last few. So almost 30% of the survey respondents told us that they had seen or heard more about end-of-life care issues in the past 12 months than they had in the year previously. Of those who completed a healthcare proxy, 15% named their agent in the past year. Of those who talked with a healthcare provider, about 40% of those conversations have occurred in the past year. Nearly half of those who had a conversation with someone other than a healthcare provider did it in the past year. This is the work that all of you are doing. I want to just point out something that did not happen in the course of this last year's political debate, election, incredible divide across the country. And that was that death panels never came back. It flared at several points during the campaign in the last year. We had efforts ranging from congressmen to agitators outside of the political realm, charging various people with trying to bring in death panels. And it never came back. It found no traction because people were hearing this message. And you are the reason why. All of you, reaching all of these people, turning up in the surveys, in the videos, everywhere. You are the reason why, and I'd like you to give yourself a hand for that. I'm going to give you one example of someone who has put her vote down on where this is happening, and that's my mother. My last book, Being Mortal, told the story of my father's death and the struggle along the way with trying to come to terms with his condition and then trying to figure out how we could have a better path along the way. He died now almost 5 years ago, and my mom, who turned 80 this past year, has been rattling around in our big house in rural Ohio. I grew up in a small town in the foothills of Appalachia near West Virginia and Kentucky, the poorest county in Ohio, where they were local doctors. My mother was a pediatrician, my father a urologist. And she started to have things that didn't go so well. She crashed her car going to the local Rotary meeting. It wasn't so bad. She was in the parking lot, pulling into the slot, and then, her foot, instead of hitting the brake, hit the accelerator, bashed right into the bollard. The airbag deployed. She decided to pretend like nothing happened. Went into the meeting. She failed to recognize she was covered in the white dust from the bag and was a little black and blue in the face, so it sort of freaked everybody out. So I got a lot of phone calls after that. Having some health issues that started to arise, and we began having this conversation. It took us a couple of years before she finally could voice what her greatest fears were. She'd seen her friends go into the local nursing homes in southeastern Ohio and into the retirement communities. And they were miserable because nobody asked them what matters to them in their life, about what their purposes are, about what they cared about and loved as their reasons for living, and helped them make those things happen. And so she said, I am never going into one of those places, and I am never leaving this home. So when she was visiting here, I said, can I just take you around to visit some of the places that we have here? And she was like, no. So it was a couple more visits later, and I took her around to lots of places, to Orchard Cove, to a bunch of places I wrote about and a bunch of places that I didn't write about, but I had gotten a chance to see. And it opened her eyes, because we're places where we're asking people, and they were asking, not just how are you going to be safe and keep from having falls, and how are you going to, how much health care are you going to be able to get, but what turns out really matters. And they knew it even before we got there in some places. My mother, the pediatrician, arrived in the place that she ultimately chose, which is LaSalle Village in Newton. And they had got a former doctor to join her, the wife of a former doctor, and a scientist who at 82 still went in once a week for her lab meeting. And they enabled it to make it possible for her to continue to do that and contribute. And sitting at that table with this group of extraordinary women, she said, I have not had a conversation like that in a decade. And she said, I want to be here. And so just this past August, she moved in. And the plan was that she, kept her home in Ohio, because that was where the real community was. And she was only going to, I'll just come for a couple weeks here or there. And the result is, between now and last August, she spent about 80% of her time in that community. She's had a fall with a broken wrist. She's had emergency surgery for a retinal detachment. And yet, they enabled her to take a month-long trip to India, though she required a wheelchair for half of the places that she had to go. They have created, she was the one who introduced all of the community to Uber and Lyft. And so she gave lessons to everybody on how, because losing her car in Ohio, man, that was giving up a lot. And so she learned how to, get Lyft, and then taught everybody else, and so they make their own trips and go wherever they want, including to my daughter's slightly profane rock concert this past weekend. And that has enabled her to have a better life. That is what the promise of what we're doing can be. I know we are not there, and when she arrives at a point of illness, that she could end up in an emergency room or with one of those specialists who are not going to ask what matters in your life. And we have to be the place that just is not going to happen. It's personal for me and for you. Thank you. This is a time where we can ask questions about the coalition or make your comments about what we're doing, what you think is right, what you think could be better. And there are some microphones to go around, I believe. Yes, there's one microphone over there and one over there. So, and one, oh, there we got lots. Okay. So put up your hand. A microphone will come to you, and then so let's go over here. And I might ask for help from my compatriots if the question requires it.
Paul Hattis from Greater Boston Interfaith Organization, but also faculty at Tufts Medical School. You mentioned how most conversations between providers and people are initiated not by the provider. Is there any evidence from working with any of our local healthcare systems that certain educational strategies help providers, be it primary care in particular, perhaps specialists too, to initiate conversations? Any evidence yet?
Oh, I did not plant this question. I promise you. Thank you for that. This is, in fact, the major focus of our work at Ariadne Labs. And so we completed a trial this year. We released some of the preliminary data, but this was at the Dana-Farber Cancer Institute. And it involved, so here's the core problem that you're describing, which is that if what we say is, you know, please get to a palliative care provider, we don't have enough palliative care providers. The reality is that they can get to at best 5% of the people who go on to the end of their life, let alone the percentage of people who have a serious life-limiting illness and are on an earlier part of that journey. So the critical question is, how do we bring those palliative care skills of conversation to the non-palliative care clinician community? We created a program called the Serious Illness Conversation Guide, and that set of work involves mainly framing a conversation that patients have with clinicians around a set of questions that are kind of these basic tools of a palliative care conversation. One of Susan Block, who is the director of this work, you know, when I came to talk to her and ask her, how do you do what you do? She said, you know, and what should my checklist be for what I learned to do as a surgeon? She said, number one, stop talking so much. When you're having a conversation about what a patient needs at a critical change in their care, then you should be listening more than half the time. And when I went into my office, I found I was talking 95% of the time. The conversation we normally have is, here's your situation, here's option A, option B, option C, here are the risks, here are the benefits, here are the pros, here are the cons, now what do you want? When the real conversation is asking questions like, do you tell me your understanding of where you are with your illness at this time? What information would you like from me about what might be ahead in your future? What are you willing to go through and not willing to go through for the sake of more time? What are your fears and what are your goals if your health worsens? And who will make decisions if you can't? The training in that program is a 2.5-hour training module that we created for clinicians. We actually asked the clinicians at Dana-Farber to enroll in the program, and we had about 80% participation who agreed to enroll in a randomized trial where half of them got the training program, half of them didn't. And you asked, what is the evidence that we have? So the evidence that's come out of that program is that you had the conversations happening more, so 92% likelihood that these conversations happen, which is markedly better than what we're seeing in these survey data. They're happening earlier, so at 5 months before the end of life, instead of just the last weeks. And it's better, so instead of the majority of the time it being just a do not resuscitate conversation, what you do not want, they were a much more robust conversation that was larger than what you do not want to what your goals of care are. 90% had that discussion of what you really want. And then finally, the signs that it was better was we have had, the preliminary data showed a reduction by half in the likelihood of moderate to severe anxiety, also reduction in moderate to severe depression, strong support from the clinicians and the patients around having these conversations, and felt that it improved their quality of care. We'll have more data around resources and survival that come out of it as well. So that's number one on that. It has extended further to primary care. So we have the data now from involving 60% of the primary care physicians in the Brigham network. And what we found is that they're using these conversations, first of all, not just for people who have terminal illness, but people who have chronic illness and are making choices about the quality of life they're pursuing versus the burdens of the treatments that they're undergoing. And second, that they're matching with similar kinds of levels of achieving more, earlier, and better conversations as a result of going through the program. It's not just training, and that's what makes it tricky. It also involves the system working with them to recognize which patients are at their highest likelihood of coming to the end of life, and giving them reminders when we don't see documented in the record that those conversations have been happened and that's been entered in a accessible place. So it's a more complex undertaking. I'll add two final parts to that. Then, with the partnership with Blue Cross Blue Shield, we're extending it now to Lowell and Leahy, and experimenting with how we bring it out of just the academic settings into community settings. Furthermore, there's an online community of leaders who are implementing this work, 880 leaders from around the country, including people from across Massachusetts. And then I'll just say, that's the evidence, but in fact, there are many of you here who are doing programs like this. There's the Conversation Project's Conversation Ready program for healthcare systems, where there's similar kinds of resources and tools for achieving these kinds of goals. So, the evidence is not an indicator that ours is the only way to do it. The evidence is that when you do it and achieve these goals, it has tremendous impact. Other questions?
Good morning.
Good morning.
My name is Girish Mehta. My colleague and I are from Indian Circle for Caring, USA. First of all, I wanted to compliment and congratulate you for doing what you do. About 9 years ago, when we started this organization, we recognized the need for preparing healthcare proxy and living will. For 9 years, we have distributed over 15,000 plus copies of these documents. We have created workshops and presentations over 60 locations in 14 states in US. In addition to providing support, for people who are in hospital through serious sickness, and advocating what exactly you are saying. So I am appreciative of what you're doing. We're also partners with Conversation Project, and I were one of the first people trained on that Conversation Project as well. So my compliment to you. We'll be glad to work with Coalition and support the mission that you have in mind. Thank you very much.
Thank you. I'll just point out that in our survey last year, we had a larger sample, which allowed us to look at where the least likely populations are to have these conversations. And the least likely populations are men are much less likely than women to have these conversations. People who have had a high school only education are much less likely than those who've had a college education. And we often forget we're at the highest level of college graduation in history in the United States, and we've only reached 30%. So it's 70% who do not have a four-year college degree. And so that is a big part of the population that we have not necessarily reached out to very effectively. And then add to it that it's minority populations that are less likely to have the conversations. And so efforts like yours that are bringing these conversations into societies, and I know, in the Indian and South Asian community in general, this is a community where in the Asian culture we are reluctant to want to talk with our elders about these kinds of questions and opportunities because people see it as giving up again, and rather than how do I make sure we know your wishes so that we're being able to be the most supportive we can. So I think these kinds of efforts are incredibly important and are teaching us what are the messages that reach the populations that are least likely to have these conversations. Over here in the back.
Hi, Dr. Gawande. Len Fishman, Director of the Gerontology Institute, Boston. You struck a question, which is learning about having conversations with people of color, different racial and ethnic groups where obstacles may be different than are encountered with the rest of the population. Improve access. And before I sit down, I just want to say how incredibly gratifying it is to see the strategic focus from so many players in this state and the progress that's been made in just 12 months. It's pretty remarkable.
Thank you, Len. I'll just say, I don't think the evidence is really very good about what the critical differences in messaging need to be for people in different communities to reach the right populations. I think there will be some real opportunities this afternoon because there's going to be people presenting their work where they're reaching out to different communities, and I think this is a place where we can help both learn and innovate as we approach different communities and find out what resonates, and then in our academic community study so we can get the word out about what really matters. And I think folks like Ellen and others will, when they come up, will have a chance to describe some of what they've found works for different populations. But as far as having strong evidence right now, I think we're in the early days, very much, and there's a lot of learning to do.
Hi, Doc. Three things. First, good luck getting the tax rates, the taxes raised in order to pay for Massachusetts to fulfill its promise in providing the health care people in the states if we lose the federal money. I hope it happens. But two things. The conversation is critically important, but I just came from a friend who over the weekend, mom was in the hospital. They couldn't get her out of the hospital to go to hospice because the hospital said she wasn't medically stable. And so it's really about a continuity of care question. Once somebody goes to the hospital, the primary care provider who knows a person less, the best, is no longer part of the conversation, and the hospitalist seems to be in charge. And so you lose continuity of care, and care transition doesn't take place well. So that's a question. So how do you improve that?
Sorry, say that last part again.
Sure.
The question was?
The question is, how do you improve continuity of care and transition of care once somebody who's had these conversations goes into the hospital so that the conversation doesn't all of a sudden disappear? Because that's what happens in the hospitals. And then the third piece is regarding, God bless your mom, you brought her around all these places, she was able to choose the one she wanted, but you can't have control without choice. And that's one of the major differences between folks who might be members of ethnic and minority populations or lower economic status, that there is no control without choice. And until we give folks a sense of having some choice, folks are not going to feel a sense of control. So I want to add that to the conversation. Thanks.
Yeah. Thank you. Your comments about how critical it is that people have choice and also feel they have choice is vital. We do know from the survey data about both a variety of populations who've felt excluded in the healthcare system, whether it's minorities, whether it's the LGBT population, whether it's disabled community, that the fear that people are taking away choices, that you're not even being offered the choices that other people are getting, leads people to seek more aggressive care because on the assumption that something is being deprived of you. Add to it the socioeconomic concerns about whether you have access to the same kinds of providers and care along the way, and the making choice real is fundamental. We're lucky to be in a state where we're past 98% coverage so that some of those barriers aren't there, but as deductibles get higher and higher, now coming into the thousands of dollars, that choice becomes less and less real along the way. Then the second question is, fine, I've had the conversation, I've gotten the documentation, how do I make sure that this happens? This has been really fascinating to me because, you know, the trial that started it all in some ways, or documented it all, was out of the Mass General, where they had people with stage 4 lung cancer at on average only 11 months to live, and half of them got the usual oncology care, but the other half got oncology care plus an early palliative care consultation. And in those consultations, people would identify what their goals were for their care, what their quality of life goals were, as well as quantity of life goals. And the result of that was that people who were in the arm that got the early palliative care conversations ended up having markedly better outcomes of care. Their care matched their wishes much more. They were less likely to be on multiple lines of chemotherapy right into the last weeks The result is they had less toxicity at the end of life, more time at home, they started hospice earlier, they were less likely to die in the hospital in the ICU, and they lived 25% longer. Now, the interesting part was this was in a system where we didn't yet have a centralized place where their wishes were being entered into the medical record. The palliative care doctor wasn't there at the emergency room at 3 in the morning when they turned up on a Friday night. And yet the wishes were being followed. And I think it teaches us that there are a couple of aspects to making this happen more regularly. Number one, when patients themselves have had a chance to articulate what their wishes are, they're more likely to be the ones who simply draw the line and say, I'm now being subject to things that I don't actually want. And so the powerful voice of the patient is, to me, what that study brings through. Secondly, the second most likely person that they will have then communicated those wishes to is their family member, and that family member who is the advocate, who might be there in the hospital or wherever they are, being part of that conversation becomes the second line of being able to ensure that the wishes are followed. So I don't want to underestimate how important the community is in making that happen. That said, what Alice Bonner talked about with starting to make those wishes turn up in a centralized location that can be accessible to everybody from the EMTs to people in the chain of care across different institutions, that's the gold standard. Oregon has done this. They have done it where those wishes are now documented for about 15% of the population, and a much higher percentage in particular of people who are in the nursing home population and people with advanced illness, and it's able to follow them wherever they go. And I think some of the work in the Digital Health Initiative will be critical to making that happen. So thank you for both those questions. Do you have anything you might add to that, Ellen? I should ask, because I know that might be some of what you're also involved in, trying to think about how you make a centralized place for for people to have their wishes heard.
No, I think it's critical, because if you have an advance directive in Massachusetts and you have a crisis in Texas, you're in big trouble. So it's critical to have it across state lines and nationally as well as locally.
We'll take one, and let's take one more question. This will be the last one. Go ahead. Yeah, I want you to take the microphone.
Hi, my name is Chihiro Sato. I'm with the Joslin Diabetes Center's Asian American Diabetes Initiative. Thank you so much for all the information. That's very helpful. Personally, I recently just completed the proxy at my PCP office last week. And I'm originally from Japan, so my challenges were that I choose somebody that I can trust, as well as who is bilingual English and Japanese, because majority of my family are still in Tokyo. So in case of emergency, that person has to be able to communicate what's going on here to my family over there. So it turned out that I had to choose somebody who was out of state. And as I was filling the form, and then medical assistant and I was talking, we've noticed that there's no field for the email address. So one of the things that I thought about is there a certain form or the standard that you're trying to push? Because now it's 2017 and everybody checked their smartphone for emails, and maybe it's more accessible when you really need to go over the time differences. And also the secondary, when I was talking with my potential agents, they were all not familiar with the process. So they asked for the basic information. How much are they going to hassle us? Or how much are they trying to reach us in case of emergency? And how much can we depend on the staff at the hospital or the PCP office to keep reaching them? So I thought that it would be great if we had some kind of brochure or information or web page that I could relay it to my potential agent or the assigned proxy. So I was just wondering if you have an initiative to push forward those for the layman in the state to learn more about it. Thank you.
Fantastic. Thank you. I have two people. I have two people I'd love to get their help on, if that's okay. One would be Alice Bonner, who's been thinking a lot about how we modernize these forms, and I don't know what direction you might suggest we have that we could move. And second, is Ellen DiPaolo here? Oh, good. And if we could get a microphone to Ellen from Honoring Choices, where they've done an extraordinary amount of work connecting. I think you probably have something to say about the tools that we've got and what can be done better. So.
Thank you. Yes, so I definitely want to hear from Ellen as well. But Daryl Villaruz, who is here, and Associate Commissioner Lindsay Tucker, again, as I had mentioned, both are working on what started out as our Massachusetts MOLST form, but now we're looking at standardizing and having it be related to the national POLST paradigm, which is physician orders for life-sustaining treatment. And so there are definitely efforts to enhance the forms that we currently have, and I would just suggest that you speak with those guys about sort of where we are now, because your comments are really excellent. So Ellen?
Oh, thank you. That's great. I'm Ellen from Honoring Choices. I hate having my back to anybody. I think what we've seen, that's a really great idea. We actually have a very easy healthcare proxy that everybody's using across the state. It's been a very consumer friendly, but what we're learning is it's not enough just to have that paper form. So we just actually, in working with the Mass Commission for the Blind, have just made the forms fillable. That's the first thing online. And then we're also considering the putting other information like the email address and a text address. It kind of gets really like a big question when you start thinking digitally. So we're just open to hearing all of that, and we're just going to keep working. Oh, yeah. Can I pass the mic this way?
Yes. More to say on this.
Hi, my name is Sue Lynn Chen. I'm the CEO and co-founder of Cake that Andrew Dreyfus mentioned earlier today. On our website, which is totally free to use at joincake.com, you can actually generate a legal Massachusetts healthcare proxy. We actually do include an email field because it is 2017. And if you create an account, which is free, you can actually directly share your medical preferences electronically with anyone that you think should know, because we recognize that a lot of our key people are not necessarily geographically co-located with us, and we think that it's really important that this information is stored securely in the cloud. Thanks.
We got one more on this.
Hi, it's Harriet Warshaw from the Conversation Project, and I think you had also asked about a tool. So the Conversation Project just launched another starter kit on how to choose a healthcare proxy and how to be a healthcare proxy. It's online, free of charge. And I think Ellen also has some resources as well on the important role of healthcare proxy. So there are resources for you.
That was a perfect way to end what I had to say, because it's a reflection of what this coalition is. We are not doing it. We're a tiny group of people who gather you guys together and then try to connect the dots. You're surfacing the issues that turn out to matter in explaining why we have not been able to make these kinds of conversations happen and have people's wishes actually honored along the way. All of you are doing work that connects these dots. They surface issues that the people are here who can actually solve, and we can then march forward, set those goals, and see, okay, can we set a set of goals around modernizing those forms and come back to you in a year saying we've got a clear commitment and a clear set of things that we can do. This is the place we begin to make it happen. This afternoon will be a set of conversations that allow you to have those discussions further at your table, try to surface more of the resources that are that people are bringing in, and I think it's a reflection of all that we can do. Thank you enormously for everything that's happened over the course of the last year. We will keep doing the kinds of surveys that we showed here, and they can help be the marker of how well we're moving forward. So, thank you.
That was wonderful, Atul. Thank you. I'm Ellen Goodman. I'm a recovering journalist and a founder of the Conversation Project, which has a nice duality today. First, we have to say that Atul may be a specialist. Nevertheless, we gave him a dispensation. He even got, if you didn't see it, he even got a thrown kiss from somebody from Orchard Cove. And not only that, but he managed to change his mother's mind. Now, that's really an accomplishment for all of us to admire. We are here today as a fascinating coalition because we are people who are working outside the healthcare system and inside the healthcare system. And we always think of this change as a kind of double helix of social change, if you'll forgive my one medical terminology, which is that people at the kitchen table having these conversations, as you saw in the survey, have an impact on people in the healthcare system, and those in the healthcare system, again, have an impact on those of us who are having these conversations with family and friends. And let's remember that not everybody has a family member to have these conversations too. So we're in the business of storytelling too, as you saw in these wonderful videos that we had, and in Atul's story about his mom. And why are we telling stories? Because stories are at the heart of social change. They're a way that we make social change. All the social changes that we have been through in my lifetime have come about in large part because people began to tell their stories. Civil rights movement, the women's rights movement, the gay rights movement. I remember myself in covering the women's movement, how years ago, every woman had a story. It was a story of discrimination, or of sexual harassment, or what we now call Bill O'Reillyism. But every woman thought she was the only one. And it was only when those stories began to be shared that change started. And so we are seeing this again in this huge social change, which is really going about at a much faster pace than a lot of the other ones that we have been through. And these stories being shared are stories of good deaths and of hard deaths. And as a recovering journalist, it's still remarkable to me that everybody has a story. I think everyone in this room has had this experience of talking about what you're doing, and there's a small pause, and then out pours a story. And some of those stories are rich and full, and some of them have been kept under wraps for years and decades, but at the first opportunity, they are shared. And that is really a big part of the work that we are doing here in the last year as well. What we heard in the videos that we've seen so far, and we'll be seeing two more, were the struggles people had and the desire that they had to have their voices at the center of their lives and the center of their families' lives at such a critical time for all of them. I was very touched by the voices at Orchard Cove, very clear. So many health professionals will tell us and tell their patients or give themselves a pass by saying, oh, people don't really want to talk about this, or people really don't know what they want. And guess what? As we've seen in the surveys and in the videos, that combination of data and humanity, people do know what they want when they have had the chance of having these conversations started. Also, we've seen that there are many concentric circles of talking, not all in one place. There's the concentric circle around the kitchen table. There is the proverbial kitchen table, whether it's actually there or not. There are conversations with family members, with primary care physicians. There are conversations between students and medical professionals, medical professors as well. And it is extraordinary how many of these people have been open enough to share their stories with us. That too, storytelling is a big part of breaking the taboo. And while we have put a lot of dents in that taboo, there's still a lot of cracks, but there is still that sense that it is still a hard thing to talk about. These are honest and loving stories that show what matters to people. As Maureen always says, what matters to people, not just what's the matter with people. and that breaks the kind of denial and silence that we started with. I just tell you, I remember clearly when I was only 25 when my father was dying on his last birthday, 3 months before he died of cancer. I went to his birthday party, and my mother, bless her heart, gave him a present, and he unwrapped the present, and it was luggage. So I don't know if that makes my family a candidate for the Hall of Fame of denial. But we all have stories like that. And storytelling, let's just remember, is at the heart of the work that we are doing in social change making. So I'm going to introduce our next two wonderful videos that show how people and their experiences are incredibly powerful motivators of change. The first one is Arle Prelo is going to be our star, a daughter talking about the death of her mother and how her family and her faith community, concentric circles, were all part of her experience.
My mother was a real generous and giving person. One of the things she did for over 20 years is she would go down to the Skid Row area and prepare about 100 meals for homeless people. Back in 1965 or somewhere, she had a blood transfusion when she had a hysterectomy. And we didn't know it until in the 1990s that she had hepatitis C, grew into cirrhosis, and then it moved more into liver cancer. So what took her to the hospital was she fell on the bathroom floor, and she went into being treated at the emergency room at Kaiser Permanente. There was one last procedure, and she came through it pretty well, and my father was there. We were all in the waiting room, and the doctor came and says, "Your mom's doing well, but the next question is, what are you guys going to do now?" And we were asking him, what is he talking about? And he says, she's dying. So we just started calling friends, close friends and family. I called out here, and the beautiful thing about being a member of my congregation at my church, Bethel A&E, is the co-pastor Gloria White-Hammond, and I called her. She was kind of in all in. She's my pastor, confidant, friend, colleague. She knew about this whole dying process, and I called her, and she says, "Do they have palliative care there at Kaiser?" I said, "I don't know." She says, "Ask for that." Since she was dying, they had made the suggestion that there was a kind of a suite there at Kaiser that they would open up, and it's not so much, a hospital room, but a space where there are, couches and places to sit. So I go in there and I stand over her as she was laying down. And, I go through this litany of, "Mother, I just love you so much, and I so appreciate you." He says, I have a question. I says, Mother, did I make you proud? Did I make you proud? And she did this thing with her face where she kind of shook her head, like, how could you not feel that way, So, okay, Mother, I'm going to go out, but I just want to say I love you. I love you so much. And then she did this whisper, like, I love you more. There was a gift in that dying, both for her and for us. I mean, for her to be surrounded by people she loved and people who could love on her. There are both things, I call it like inside of the hospital, that were important to make this happen. But there was also, I call it a community outside it, the faith community that I was a part of. People who were concerned about my spiritual well-being and the spiritual well-being of my mother and also of our family members. So it was that community, and I really feel that a community outside of the hospital sphere is an important one.
I'll be able to talk about in a minute. It was just so beautiful. And I think it showed just how we all live in so many different concentric circles, you know, that we can't just think about this as people and their clinicians. We have to think about this as people and their friends, people in their family, people in their faith communities, people in their workplaces, where we work, live, and pray, as we always say at the Conversation Project, and how critical it is for this to go through the system, to go through so that everybody is comfortable with it. Our next video is Kate Norris is telling us a really wonderful story of 2 deaths of her father and her stepfather and the huge contrast between them. And we'd like to share that with you.
My stepdad's really the man who raised me. He and my mom got married when I was pretty young. I remember him as like a very fiery guy. He's very passionate about everything. My stepdad got sick in the fall of my junior year of college. And he had bladder cancer that they found in his kidney. So my stepfather was really aggressive in treatment, you know, early on, and he and my mom were really optimistic, but there did reach a point where it was clear the chemo wasn't working, and that ultimately this would be the thing that we lost him to. And I think he had very specific conversations with his doctor. His doctor seemed to be really tuned in with what he wanted. My mom also took it upon herself, though, to start those conversations with him. So my mom had to kind of make it okay and would say things like, let me tell you what I want if I go first. And then he would say, okay, well, if I go first. So she kind of had to make it okay for him. Ultimately, in the final couple of days, he did end up in the hospital. But we were all there, and we were able to say our goodbyes, and he wasn't in any pain. And we were ready in a way. About 8 months after he passed away, my dad got cancer, and he had lung cancer. And my dad was a very different person than my stepdad, and very private, and would never want to burden other people with what he's going through. So I remember staying with him for 2 days and being like, oh my gosh, he's getting really sick and there's no plan. He was heavily medicated and was still driving himself around. Not safe. He was still working. He also lived in an apartment that had lots of stairs and was growing really weak. I went to a number of his doctor's visits with him, and the doctor knew that he lived alone and knew that he was getting weaker, but that was never a part of the conversation of we talked about the chemo and we talked about the radiation, but we never talked about how are you getting to these doctor's appointments? How are you getting in your apartment? Towards the end of his life, he was in incredible pain. And so we rushed him to the emergency room. And his pain was so bad that they had to give him so much morphine to get over that hump that within 30 minutes he was out. And so there was really no time to say goodbye. What I wish his doctor had understood, and that I wish my dad had understood, but especially his doctors, that the cancer was only a small part of what was actually happening in our lives. We weren't talking about what my dad valued and what a good day looked like for him. My dad's experience is like nothing anyone should ever experience. He deserved much better than that. With my stepfather, there was always open dialogue about what was happening, and everyone knew where everyone stood. And most importantly, we knew where Jerry stood. My stepdad's death was honestly pretty awesome. And I know that's a weird thing to say, but it was beautiful. And I feel really privileged to be able to have taken care of him. It's a wonderful thing to take care of somebody who's taking care of you. I want everyone to have the experience that my stepfather had, and to essentially have the care that they want, and to feel like they're in control of that experience.
So the power of storytelling in combination with the data is really extraordinary because it delivers to the heart as well as to the head. And we are very lucky to have Kate with us now, who I will tell you what she told me in the hall before this. She said they cut out the parts where she was really crying. So, thanks, Kate.
I just want to say how wonderful it is to be included here today. I actually read Atul Gawande's book, Being Mortal, about 1.5 years ago, and it was nothing short of transformational for me. Honestly, I read that book as like a call to action, and pretty soon after I left my job to re-navigate my career towards this work. So this public dialogue, it really matters, and it really has an impact. So thank you, Atul. I'd also like to thank the Coalition for everything that you're doing to advance this work. I've seen firsthand how powerful a good end-of-life experience can be, and it is possible to have a really wonderful end-of-life experience, so thank you for making that possible for more people. I'd also like to take this opportunity to introduce Arle Prelo, who you saw in the previous video. Arle, if you'd like to stand up. And just once again to acknowledge the other video participants that are here with us today, if you guys would all like to stand up. So on behalf of all of us, thank you for listening to our stories.
Thanks so much. And now all that stands between you and lunch are a few thoughts. So much wonderful work is going on in this room that we couldn't highlight it all. And one of the best parts of being in a coalition is that we really learn from each other. And so lunch is a wonderful time for learning. And that is the goal of this lunch. I have here this talking stick, a very official looking talking stick. It's the one that family therapists always use to make everybody in the family have equal time or have their moment for having their say. And so we have 50 minutes to eat and talk. Please take at least 5 minutes to share with your table mates one of the most important projects that you are working on, what's worked for all of you, what are at your table, and what hasn't worked, what the challenges are, and what you might learn from each other. And pass it to the next one at the end of your 5 minutes, and then we will gather together again after lunch and share some of the learnings, and our leader, Maureen, will take us on that journey. Thank you so much. Good afternoon. Okay.
Am I okay? Oh, here we are. Okay. Good afternoon, everybody. So I'm Maureen Bizignano, and I have the great honor and privilege to co-chair this coalition with Atul Gawande. And I am so struck this afternoon by the conversations that I've been hearing over lunch. Here we are talking about serious illness and end of life, and there's so much joy in the room. It's incredible, isn't it? But I think really it's because we're finally in a place where all the challenges that we are up against day to day in our careers are being shared by a coalition, a group, a collaborative of people who are similarly passionate about solving the problems that Atul was describing this morning. So first of all, I want to say thank you all for being here, for all you've done in the last year, and for all you will do. We've got a great session this afternoon. You can hear from the buzz in the room that a lot of you have made some progress already, and we want to spend some time this afternoon by having some of you begin to share. Now, we won't be able to hear from everybody in the room, but we have made a way for you to send your stories in. We want for us to leave at 2 o'clock feeling very much a part of a community. And so you'll be getting newsletters and updates and stories, and we want you to feel very open about sharing the progress you've made, the challenges that you face, and to begin to use all the resources that you've got here today. Speaking of that, all the videos that you saw today will be available both on the Conversation Project website and the Coalition website, and do feel free to use those so that you can take those back and begin to create your own momentum in your organizations. I wanted to just start by saying that I do feel in this past year that the conversation is changing, not only here in Massachusetts, but around the world. Yesterday, I was in Doha, in Qatar, in the Middle East, and I flew home, and it was a very long flight. And so when I'm on these long flights, I have to make friends with whoever's sitting next to me. It's just the way I am, Irish, you know. So I sat down next to this guy, and we embarked on almost an 8-hour flight. And so we started talking, and he said to me, "So what do you do?" So I said, "I'm in healthcare." And I said, "What do you do?" And he said, "I'm an economist." And I was thinking, ooh. We've got a long way ahead. But as soon as he said, "You're in healthcare?" I said, "Yes." He said, "Can you help me?" I said, "Absolutely." And so I said, "What can I help you with?" Well, he pulls out The Economist. And the title is How Life Ends. Death is inevitable, a bad death is not. And he had just finished reading this, and he said, "I'm struggling," because he said, "I need your input on morally, what's my obligation to raise these issues about end of life when I'm doing financial planning?" And I said, no. People feel very comfortable to talk to you about money at the end of life. They feel very uncomfortable talking to me about the end of life. As Atul was saying, the numbers are quite amazing. 23% of people have worries about talking about finances. 71% have challenges talking about end-of-life decisions. So if you haven't had a chance to pick up The Economist from last week, do. It talks about Atul's work, it talks about Ellen's work, and it talks about everything that we're here today. But to have this be on the cover of The Economist is really quite, I think, a sign of the progress that we've all made over this last year. The whole article is about power. It's about sharing power, and it's about the ability for all of us to say what we want and to assure that those wishes get respected. So over this last year, as you heard from Andrew this morning, we've gone from a smaller number of people working in this room to a much bigger number. And the progress that each of us is making individually and then collectively is inspiring. So we've asked a couple people this afternoon to begin to share some progress with the idea that the progress and the ideas that you all are going to hear about might fertilize an idea for you to take back home. So we're going to have some people share ideas. I'm hopeful that we'll have room at the end to have a few other people share ideas. But then know that the website and the emails that you'll get will be a continuing conversation about the kind of progress that we can and need to all make together. So I'm going to start. Each person will talk for 1 to 2 minutes, and that we'll just rotate through. After a couple of people have spoken, Atul and I will do a little bit of reflection. We'll have a few more, but that's how we'll spend the next hour. So David, would you be willing to get us going?
1 to 2 minutes is tight. I'm David Sontag. I'm Deputy General Counsel at Beth Israel Deaconess Medical Center. So I'm just going to tell you a little bit about some of the projects we've been working on. So we have a pilot to increase the percentage of patients who've completed healthcare proxies in one hospital-based primary care practice. We're continuing on that. Our goal is 95%, and we're hovering right now around 85% of patients having completed their healthcare proxy in that one practice. We're also doing 2 different research studies, one about that pilot program so that we can learn what works and what doesn't work as we're trying to get patients to complete healthcare proxies. And then we're looking at we're also looking at what factors may contribute beyond our efforts to patients completing valid, legally enforceable healthcare proxies. We've changed our residency teaching so that we're changing the language we use to teach residents how to talk to patients about code status and advanced care planning. You heard a little bit about, Andrew stole my thunder a little bit, but you heard a little bit about the Red Sox. So we have a medical all-star program that we get to do at the Red Sox, and we honored Lachlan Foro, who you probably all remember from last year, as our medical all-star on that day. He also got to throw out the ceremonial first pitch. And so we use that time to not only highlight Lachlan's work, but also encourage everyone in the stadium to complete a healthcare proxy and have conversations about advanced care planning. And the Red Sox also showed a 30-second clip that we had produced about the need for advanced care planning. So that went up on the Jumbotron about 20 minutes before the game started. So lots of people saw that. I was in it, so that was especially cool. And then just real quick, at the Boston Bar Association, so I sometimes wear 2 hats, Rebecca Benson and I conducted an educational session for healthcare and trust and estates lawyers about advanced care planning, what trust and estates lawyers should and shouldn't do when they're helping their clients, and we're looking forward to putting on that program twice a year. Thanks.
Good afternoon. I'm Paul Kasuba. I'm the Chief Medical Officer at Tufts Health Plan. I'm also a primary care physician who continues to practice and a son who has a mom and 2 in-laws, both in their mid to late 80s. So for me, this is both personal and professional at this point as far as my experience. At the health plan, though, we had looked at serious illnesses over a period of time and recognized that we had a lot of clinicians actually within the plan, a lot of nurses who function as case managers. So a few years back, we decided to bring the Schwartz Center Compassionate Care Rounds to the health plan, second health plan to do that in the country. It's actually provided a forum for about 200 to 300 individuals to meet about 4 times a year to really discuss some of these issues that are really challenging to deal with on a day-to-day basis. From that, we kind of expanded to some of the things you've heard about today, which included bringing in the conversation project to have a discussion with our case managers, to effectively train them into how to have that conversation, to bring that out to their families to do that first, and then once they were comfortable with that, to at least have them armed so when they do go out into the community and they're working with our members as patients, they can actually have those conversations with them. We've also started to embark upon the project on honoring choices. And this is also something that we're active in doing at present and doing the same type of rollout, so kind of teaching the teacher and then being able to move that out into the community. We've recognized that one of the challenges is dealing with physicians and other groups within the community and making sure they have the time, experience, and the understanding about what they need to do. And so as a result of that, we've also tried to outreach to them by educating them. We have regular conferences. We convene groups, including oncology, palliative care, to try to discuss these issues and to make sure that people are understanding each other's positions. And then finally, as a plan for our own employees, recognizing that this is extremely important as part of our human resource activities in planning for retirement estate planning, 401k. Many of our individuals meet with Fidelity representatives and have conversations about how this can play into that estate planning process. We do that either through individual meetings or through group meetings or lunch and learns. So those are a few of the things that we've done over the last few years.
I'm Don Guadagnoli. I'm the Chief Medical Officer for Cape Cod Healthcare. I'm an obstetrician by training, so I started off my clinical life at the other end of the spectrum. But as I joined Cape Cod and spent more time on the inpatient side, one of the things that we rapidly identified was the amount of stress that both families and frontline care providers were finding around the decisions and whether or not the right things were being done consistent with patients' wishes as they were approaching end-of-life situations. We decided that the way that we wanted to try and help solve that was in a multifactorial way. First, we wanted every adult on the Cape, 18 years or older, to have a healthcare proxy form filled out and a knowledgeable agent who understood what was important to them. And also anyone with any kind of advancing chronic illness really needed to have a MOLS form or a comfort care measure form that was appropriately filled out and documented. We also really wanted every clinician, every frontline clinician, from the EMS driving to the door to the intensive care unit folks, to have access to those decisions that had been made and to that documentation. We knew we weren't going to be able to solve this ourselves. On the other hand, we looked at it and said, you know, we've got really a great petri dish. Because if you look at us and cut us off at the bridges, we're relatively isolated and we have a tremendous amount of the population, and we have a very substantial portion of the population, almost twice the national and state average, that's over age 65. So we had a good opportunity to reach out to folks. What we did was try to bring the community together first, because we recognized we needed to have some volunteers to help us with this effort and people to help us with the outreach. So we brought together folks from not just the medical community, but the legal community, wealth management community, elder services, financial services, and pastoral care, and held our first summit in October of 2015 under the guidance of a steering committee to make sure we got to the right place. Out of that summit, we had about 200 people attend, and out of that, about 75 of them have continued to be ongoing members of an ongoing task force for us to reach out. As an institution, we did what most of us learned during our internship, and that's that if you really want something accomplished well, a doctor needs a good nurse to be working with them and to bring forth the organization and really to make sure things get done. Tina Soares, who's here with me, was that nurse that we moved into that position and being responsible for bringing this healthcare effort out to, I've told her 200,000 healthcare proxies is our goal for Cape Cod Healthcare. So we also recognized that what we were trying to do was to eat an enormous elephant. We were only going to be able to do that one bite at a time. And we've done it in various individual bites. The first thing we did was send Tina out for some training. We'd had Sharp Healthcare, who's done this, come into our summit. We sent her out to Gunderson in Wisconsin to see what they were doing. And as we progressed, what we actually realized was that here in Massachusetts, we had great resources to partner with, and we didn't need to build anything ourselves. We partnered with Honoring Choices and with the Conversation Project to help move these efforts forward. When we brought our translation services into the fold, we brought them in with the idea of being respectful to the various communities across the Cape, but we also learned a lot from them. For instance, we teach everyone to make sure that they put their forms on their refrigerators, and apparently within the Brazilian community it's next to impossible to find people who put things on their refrigerators. So we've learned a lot by involving a lot of people from across the Cape. We've got EMS involved with us. We're in the process of training volunteer facilitators, the goal being to be in every church, synagogue, library, senior citizen center, assisted living facility, any place that we can get access across the Cape to sponsor the discussions. We want to sponsor the discussions. We also are working with our physicians to have continuing medical education programs, as well as with IHI to have to help identify and develop best practices, as well as with our homeless shelter to see what we can do to reach out to that community. So basically, we've tried to approach this in a global way, recognizing, again, though, that we can only eat that elephant one bite at a time.
Hi, I'm Gloria White-Hammond. I'm a physician. I'm also co-pastor at Bethel AME Church in Boston. I have a couple of initiatives about which we're excited. Over the last couple of years, our congregation has supported over 100 individuals to engage in conversations about their wishes for end-of-life care and to actually document those wishes. in working collaboratively in small groups. They've done a great job of supporting one another. We have realized how intensely pastoral that experience is. So we actually now have an individual who spends a day a week providing that kind of pastoral support. With now 100 people having done this, that for us is about a third of our weekly attendance. And we are finding that it's starting to shift the culture so that now when we say planning ahead, people know that this is what we're talking about. And it is starting to get easier to have people actually do the training. And we're working with the 5 Wishes document. So we're looking forward to going forward with that. Our big interest now is how do we engage younger families, younger individuals to have these conversations as well. The second project in which I'm engaged is working with community-based clergy. I'm working with a group that includes physicians from Dana-Farber, Brigham and Women's Hospital, a chaplain from Brigham and Women's Hospital, and other community-based clergy. 3 weeks ago, we hosted a conference for community-based clergy to introduce them to the Serious Illness Conversation Guide. We worked to train them at a version adapted for community-based clergy. We were sold out 3 weeks before the conference and got great evaluations. And so now we're looking to figure out how to refine the tool still further so that it can be even more accessible for people who are doing shepherding work in the community.
So let's take a moment, Atul, for a few comments and reflections from us on what you've heard so far.
Well, I think the things that are really interesting to me, first of all, is the level of ambition of this work. I mean, it's extraordinary how much people have taken on in order to advance the ball. The other thing to me is the little nuggets that suggest how they're doing it, like the description of the caseworkers who their first task is to go home and do an advance directive with your own family as a safe space. First of all, it's a nice way to go have the conversation you've been reluctant to have. It's a homework assignment. I got to do it, right? But second, it's a safe space to practice and get it wrong to a certain extent, and then take that and go further. And I think there's a third aspect to it, which is that it is a place where you get stories and you can then bring your authentic self to the next conversations with people because you've had this conversation with your mom or your dad or your grandmother or your grandfather. And so those are incredibly important things, and I think that's what is coming across from them. The second thing is that it is a wider idea of the world of the caring community, and it is the pastoral care that matters, or it might be the caseworkers who are really becoming trained. And I just was struck because it resonated with me with one person who'd come up in between during lunch. It's a woman, and I forgot her name, from Coldwell Banker, who's a real estate agent. Do you mind if I single you out and you say your name for us? They're in the back. Do you mind saying what your name was? Bunny. And she talked about the idea that, there are elderly or people with illness who come looking for homes and a change in home. And learning these skills and getting to be able to have these conversations, that she's often the one who is having a discussion about, well, what are your real goals about where you're going, and how do we make sure that we're finding a place that's aligned with what you're really looking for? And, it's always someone new at these coalition meetings that end up bringing out my sense of how much wider this is than the places we've thought that these conversations happen.
To build on that, at the lunch break, I was hearing from somebody who was saying that two people met in a meeting, didn't know each other, but neither one had another proxy. So they found themselves becoming friends and becoming proxies to each other. So I think that idea of thinking more broadly about the world that we're living in, whether it's the homeless shelters or the pastoral sites, I think is going to really give us a sense of abundance. It's going to help us to see all of the assets in the community. And the second thing, to build again on one of your points, Atul, was the sense that this is a team. This isn't one doctor, one patient. That the more that we can build on your experiences in building teams, I think the better. at IHI, as an example, we have the IHI Open School. And in the Open School is free online courses on having the conversation. And so I would encourage you to use that as a resource, as well as all of the videos in getting the stories out. And the third is, I'll push you just to make sure, have you all had the conversation? And Ellen and I did a session with the staff at IHI, which is very young. The average age is about 33 years old, but heavily weighted by a few folks. But we had a little training session and told personal stories. My brother, my mother, Ellen's sister, Ellen's mother. And at the end, we gave the staff an assignment to take the next couple of weeks and go out and have the conversation. And because of the youth, as you were talking about, it turns out that it was a challenge for some people. One of the young women came back after a couple of weeks and said she had taken her parents out to dinner 3 evenings, 3 nights, 3 weeks in a row, but she couldn't start the conversation. And so finally her father said, "What's the matter? Are you pregnant?" And she said, "No, I wanted to talk to you about dying." He said, "No problem," you know? So it does turn out to be easier once you can bridge that "I'm not pregnant" conversation, I think. But I would give you that homework assignment, as Atul has said, just to make sure that you've had it, because if you haven't had it, it's really hard, I think, to go out and convince other people about how powerful this is. Okay, we're going to hear from a few others. Julia?
My name is Julia. Can you hear me? My name is Julia Ragland. I'm a physician at Newton Wellesley Hospital. I've been a hospitalist for many years, and I'm the director of the Palliative Care Service. Our hospital has been working on all of the goals for the coalition, but this year in particular, our project goal is to educate all of the staff at Newton Wellesley Hospital about the importance of having a proxy and encouraging everyone to have conversations over time about what matters most to them in the event of serious illness. We've used a number of strategies to get the word out to our staff. Key components, I think, a foundation is that we have an amazing multidisciplinary team that has been working on the planning and implementation. This includes physicians, nurses, spiritual care, the chair of the Patient Family Advisory Committee, someone from media relations, and also the director of volunteer and community outreach. So that committee has been absolutely instrumental in coming up with strategies that would be effective. We've had a media campaign including digital signs, email announcements, particularly during the week of National Healthcare Decisions, week, month, day, whatever it is, it's a year. We've updated resources on our internet and intranet, and a social media campaign. We had tables outside our cafeteria during the week of National Healthcare Decisions Week. And one of the things, we created a sticker, which hashtag life goals, which we then hand to staff who would come over to the table, and had a raffle as well to try to entice people to come over. And we really have also embarked on a year-long educational effort in terms of going to meetings on the floors with the nursing units. I went to a managers and supervisors meeting, which is much bigger than I expected, about 100 people in the room, and basically give the case of why this is important. And as a hospitalist and palliative care provider in the hospital, every day we see how much families and decision makers suffer, and how we really believe this is preventable harm, and really liken this to, someone said their primary care asked them about seatbelts, but they never asked them about healthcare proxies. We want this to become routine as part of the daily dialogue between clinicians and patients and families. So we're actually going to explore whether we can include this with like employee flu shots. You know, we get a sticker when we get a flu shot. How about if we give them the information about the proxy and they get a sticker on life goals as well? I was asked to just comment on challenges. I think it is hard. We have a lot of competing demands, and the time to go out to meet people one-on-one where they are is a challenge. We also really don't have any support to collect data and measure the impact of what we're doing, which is disappointing. And I would just emphasize what people said earlier, the impact of stories seems to have much more impact, when we give the brief talk, which is only 10 to 15 minutes, and can connect with people in that way. And I think they also have time to personally reflect. It seems to be much more effective than having a table where it seems very transactional. And that's it. Thank you.
Great, thank you.
Thank you, Julia, and excuse my back. My name is MC Sullivan. I'm a nurse attorney bioethicist who is the chief healthcare ethicist for the Archdiocese of Boston, so this is something completely different. I'm here in my capacity as the director of the Initiative for Palliative Care and Advanced Care Planning. This is a new initiative that has been started, well, we actually just kicked off our third year at the Archdiocese of Boston, and it came out of Cardinal O'Malley's tremendous and abiding interest in palliative care, something that he has integrated into his pastoral work since the subspecialty started 20 plus years ago. So what we were starting out originally to do was to educate people in the parishes, you know, the people who sit on the benches every week, about what palliative care is, what advanced care planning is, how important they are, and how consistent they are. In fact, they embody church teaching, which is sometimes misunderstood both inside the Catholic community and outside the Catholic community. So we started by getting in touch with parishes and saying, wouldn't you love to have a presentation on palliative care? And truth to tell, as funny as that sounds, everybody is interested in having a presentation on palliative care. All of us have heard today, both in the remarkable stories, and I thank you for your generous sharing of them, in the videos and in the anecdotes that we've all shared in conversation. We are all up to our earlobes in caregiving, whether it's we ourselves who are dealing directly with parents or siblings or our children or friends, or whether we just see it coming down the road to us and wanting to get more and better equipped for the moment that it reaches us. We're all involved in caregiving. So initially we thought, well, there are about 300 parishes in the Archdiocese of Boston. We'll just go out. And when I say we, I mean me. We'll just go out. And soon we learned that probably clusters are the way to do it. But the idea was that we would go out and in the intimacy of people's home faith communities, we would be able to have conversations, we would be able to teach them and help them to join a conversation that's already happening around the country and around the world. Give them the language, give them consistent definitions, give them a better understanding of what palliative care is and what it isn't, and what advanced care planning is and how crucial it is to good care for serious illness. So we started doing that, and then we realized, well, that's really important, and we are continuing that, and I'm happy to say that we really are we now. I have a new colleague here, Diane, if you raise your hand. Imagine in a faith community these days being able to have a new hire. We do. We are continuing those because of the importance of the small, intimate settings that we have in parishes, and that primarily is the way in which folks learn, right? They share, they hear other voices, etc. But in order to go home or go big, we decided to go big. And so I said to the Cardinal, this is only going to work if we make this organic. It can't be a Band-Aid that's applied even on a regular basis. We need to have within each parish and each collaborative cluster of parishes, we need to have a resource group. We need to have people who won't have to do heavy lifting, but they can give out information about palliative care when the rectory gets that call about someone in the community who's seriously ill. When folks call and say, Father, what do I say? What do I do? What are my questions? What are my choices? And so we provide information, we provide materials, and we give them advanced care planning documents. And some of them will work for some and others will work for others. So we give them a whole smattering of documents that are out there, from the Conversation Project to 5 Wishes to 3 Beliefs to every number that you can think of in the books, and see what works. But what we're working on now, and this might be interesting for others to use who do community outreach or public education, we're working on a short track so that people aren't just given a brochure or booklet, which is great for the long conversation, but when someone finds out that there is serious illness in their family and palliative care has not been mentioned, how do they mention it? So what we're trying to come up with is a 4 or 5 question card that people can carry with them and say, doctor or nurse practitioner or PA or whomever is providing their primary care or directing their care, what about this? And give them a couple of questions to get the ball rolling. So that will be a useful part of our toolkit too. Back to the idea that there are 300 parishes. We are very lucky in the Catholic community in that we have print media at our availability, and so we work not just with the Boston Pilot, but because the Boston Pilot is the oldest Catholic newspaper, it's a weekly in the country, much of the material in it gets picked up by national Catholic newspapers and magazines, and so we use it and they work with us really well. We also have a Catholic television network that was started in Boston, and therefore much of what happens in Boston gets picked up. So it's seen around the state, but it's also seen around the country, and we know that's working because now we can walk into hotel lobbies and have somebody say, "You're on television, aren't you?" Then you kind of push them and say, "And what did you hear?" In any event, the challenge is the same challenge that you all have, and that is just upping our game. How do we exponentially increase what it is that we want to do? So in addition to the use of the media, every year we have 2 major events to which everyone inside the Catholic community and outside the Catholic community are invited. In the fall, we have a Train the Trainer workshop. And the Train the Trainer workshop was originally in my head designed to get the resource groups trained, who will go out and go back to their home parishes and get to work. And it's doing that. But we're finding that colleagues from around the state are coming. We have several of the non-Catholic healthcare systems who routinely send their team members. They want to know what it is that their Catholic patients understand about teaching, or what perhaps maybe Catholic teaching has to tell everybody. You know, we kind of go back a little bit of the way in caring for the seriously ill. So there's some of that. The Train the Trainer workshop has been filled to capacity for 2 years in a row, and we're hoping into infinity. That happens in the fall. And then in the spring, and Andrew mentioned it in his comments, thank you very much, we have an annual palliative care colloquium. And that's really both meant to educate and inspire. It's kind of a pep talk. Last year we had the theme of just how do we integrate palliative care. It's wonderful to have palliative care specialty teams and groups and services and programs, but how do we integrate it into not just the care inside our healthcare systems, but also inside the care of the community. The support networks come from the community. So how do we educate those people and inspire them? This year we specifically looked at the topic of spirituality, and not just the spirituality of patients and families who are suffering serious illness, but for the caregivers who take care of them, the professional caregivers. And we had some wonderful folks come and speak about that. So that's what we're doing. I'm happy to answer any questions, and I thank everybody who organized today, and especially for the opportunity to tell you about our story. Thank you.
Hi, my name is Susanna Makovsky, and I'm co-chief of palliative care at UMass Memorial Healthcare. And we've been involved in a few different projects. One of them has been actually partnering with a web-based, cloud-based technology on advanced care planning that we helped build some of the language content on with the advanced care planning tools that include issues of, first, how do you choose who you want involved in the conversation? Not just who your agent should be, but who in your family do you want to know, and to what extent do you want them involved in? Who of providers or clergy or others do you want to have listed? So it goes beyond the healthcare proxy to who's going to be that circle of advisors for your healthcare proxies, with an option to have their emails, and once the whole advanced care planning is filled out, it automatically can be at the patient's discretion email to these people. In there also, the next stage is to talk about where are you in terms of your illness and your well-being. And that then helps decide with the program the intensity of language and questions. For all patients, there'll be issues around values, and as Dr. Gawande says, what matters most. So in there is what matters most to you in terms of function and family and wishes as to where you are today in your life and in the future. And then finally, that will inform issues around goals and medical decision making. Once that form is completed, it is sent to the patient in a PDF, and it automatically uploads into our EMR. So anytime the patient edits again, a new form is uploaded and updated into the electronic medical record so that the primary care doctor, the specialist, including surgeons, can access it. And it's a tool that actually has served, it's growing a little bit, but one story that I'd just like to share is I was called as a palliative care doctor to see a patient at 4:30 on a Friday afternoon when they were about to be discharged. So I met with the patient and her son. She wasn't very internet savvy, but her son was. So I gave them access to the tool, explained to them how to use it, set up an appointment with my colleague, Dr. Reedy, for Monday. They spent the weekend talking about it, using this tool. The son helped her fill it out online. And by the time they went in to talk to their palliative care physician and their oncologist on Monday, they really had a lot of information and tools to help finalize that document and auto-populate a Molstan healthcare proxy. So it was a nice pilot. We're yet to see what's going to happen with the next rendition of it, but that was one big project that we did. With this, we did two other things. We engaged also in employee health. So it couldn't cross-pollinate with our other EMR, but we linked it actually to wellness points. So any employee who completed their electronic advanced care planning form would get the same number of wellness points as a flu shot, and towards getting a free gym membership for the year. And then the other piece that we did with it was a competition among the medical students. So to engage a younger population, our medical students who have houses kind of like Harry Potter mode, the house that had the most number of completed advanced care planning forms and healthcare proxies got points towards their house cup and free pizza. So, that links to our other initiatives, which are around education. And one of the big projects that Dr. Reedy actually was a lead on was building an OSCE, which is a standardized patient platform, or utilizing actors to help teach medical students, and after coaching hospitalists and other primary care doctors, how to evaluate students on doing advanced care planning and goals of care discussions. There are only 4 palliative care doctors in the 800-bed hospital of UMass, so we couldn't do all the teaching because we have other duties, but we taught hospitalists and others to do the teaching. Now that has been adopted, every second year internal medicine resident at the UMass Health System goes through this training, and it's run by the Hospital Medicine Service, and all the hospitalists are strongly encouraged to go through the training as well. They're hoping to expand this and look to doing control studies perhaps in other settings and looking to see how it's going to evolve. And then recognizing that this also requires a team approach, we've engaged community health workers through our ACO and case managers to get trained in some of these tools. And also our nurses in the hospital have identified that because they play such a role at the bedside and are there when the specialists aren't, or often when other people are harder to access at night, and also they know the patients at a level of intimacy on the inpatient side in a way that perhaps other people don't, specifically doctors. So we've developed a palliative care scholar program for nurses, and the goal is to have at least 10% of our nursing workforce trained in palliative care, certified in palliative care, with a piece around advanced care planning. And lastly, one of our community hospitals, and we're hoping to expand this throughout our system, has partnered with Honoring Choices Massachusetts and is integrating all their tools into their wellness set, into their training of their staff as well. So these are some of the work that we're doing at UMass, and I'm available for questions. Thank you.
Hi, I'm Kathleen Petrowski from Harvard Pilgrim Healthcare. So I'd like to tell you about some of the activities we've been involved in the past year. One of them is that we added an advanced care planning benefit for reimbursement at the beginning of 2016 for the advanced care planning codes. I have to say they aren't used as often as we'd like to see them used, so we're doing our best to share that information on our provider website, etc., to increase the use. Our Massachusetts medical director meeting, the last one we had, was focused on palliative care and chronic illness. And we looked at palliative care in the outpatient setting. We had someone from the Serious Illness Conversation Project and had a panel discussion about engaging primary care patients and families in advanced care planning, and heard a lot from primary care physicians about primarily about the challenges of doing this, though some were soldiering on and able to speak with their patients. Related to the primary care, we are funding a quality grant this year for a primary care practice who's implementing the serious conversation. They have both pediatrics and adult, but they've interestingly decided to start in pediatrics. So they have a champion pediatrician who is looking at kids who she doesn't expect, would make it to adulthood. And quite a variety of different diagnoses, and she had taken the training at Ariadne and then brought it home to their practice and has already used it with numerous kids. And one of the fabulous parts about it is when they're done having the conversation, I have to say every family she's invited has been more than happy to come in and have the conversation. And with their permission, the information's been shared with the specialists because all the kids have specialists involved who have been really interested in how it came about. So anyway, they'll be continuing with that project for the year. Their next step is once they have it well established in pediatrics, they're going to move to adults for their practice. Also, Harvard Pilgrim and Care Management, our Harvard Pilgrim nurse care managers do ask all members that they're engaged with if they have completed advanced care planning. They do provide education and resources for advanced directives or planning based on the state the member lives in, because we do have patients in various states. We also had a big focus on employees. Well, we're not quite finished. We just got started with that. We also had the campaign in April with the tables in the cafeteria. We were providing information on advanced care planning and healthcare proxies, and actually a number of employees signed them on the spot. They had been thinking about it and presented with the opportunity, took care of it. Others were, prepared to go home and have conversations at home. We also had a table where you heard about the CAKE program earlier. We also are involved with them, as well as Blue Cross being involved with them. So we'll be continuing with that this year. So our next steps, we are going to be updating our website both on a provider, member, and in-house company website with much more information about all of it, palliative care, advanced care planning, etc. We're going to continue with lunch and learn sessions for employees, and we are evaluating our palliative care and hospice benefits just to see if there are any recommendations needed to improve on those benefits. Thank you,
Kathleen.
So a couple of themes come out to me that stuck in my mind from all of these. Number one was at least two folks, MC and Julia, were people I'd met with last year and heard about where they were in their work. And it is stunning how far you have come. Mm-hmm. You were doing a lot last year, and I was blown away by what you had done last year. And then you seem to have taken it up to a whole nother level. And I think it's a sign of how much growth is happening and is underway. The second part is that people are engaging their employees, and I heard that as a common theme, which wasn't there last year, and the ways that people are using wellness points and that whole set of work around wellness, I think, is something that we've heard across many places and is an opportunity to engage people in being able to have these conversations and fill out some of their own forms themselves, and that's a fantastic opportunity. And then the last thing is I love that there's a subtle competition underway to list even more of the work that you're doing, because I think we all end up feeling like, oh, geez, have we done enough? And so that's a good thing to hear about all the unbelievable things that people have underway.
Great, thanks. So we have a few more before we wrap up. And so are you going to go, Aileen? Harris.
Good afternoon. I'm Harris Berman. I'm the Dean of Tufts University School of Medicine. have to tell you, when I woke up this morning and went to the door and got my Globe, sat down over breakfast with my coffee, and opened the front page, my heart sunk as I thought, there goes the talk I was supposed to give this afternoon. But for those of you who didn't read the Globe, let me tell you what we've been doing on our end of this. I was asked by Atul to coordinate an effort with the 4 medical schools here to collaborate on developing curricula that will teach our students and then the residents and the faculty how to approach these issues. So I called all of the deans and told them that Atul's behind this and asked me to do it. And I got to tell you, that's an easy sell. And they all readily agreed. It took about 5 months for us to pull together the meeting, though, just because everybody's schedules are complicated. But just a couple weeks ago at our Ariadne Labs, we had a meeting of the deans of education, or deans of academic affairs. They call it different things, but it's the same job in different medical schools. And they got somewhat into the weeds of what it is that we want to do, how can we do this together. And they agreed to do this and agreed that the next step is to involve our faculty who teach palliative care and our faculty who teach geriatrics to come with the deans of education together and share best practices, and then figure out how do we put all those best practices together in a way that we can make students comfortable with this, and then go to our faculties, which include the residents, and teach them how to teach this, and that way spread it through the system quickly, not have to wait for our medical students to become practicing doctors for this to have any effect in the community. And what we really want to do is to make them as comfortable talking about this as they are talking about other sensitive issues, whether it's asking people if they feel safe at home, which is something we never asked back when I practiced medicine, but now it's a routine part of the visit, just as asking people if they smoke or wear seat belts, and part of the discussion should be what are their goals. And because their goals change as time goes on or as their condition changes, this isn't a one-time conversation, but it's a conversation that's best started when they're healthy and started with the very first visit as part of getting to know the patient. But then it needs to be followed up as conditions change, because people's thoughts change and things that they never thought they'd put up with as they get closer to the end of life and they don't want to give up, they might be willing to put up with. So as others have said, patients are ready for this conversation. We have to get providers ready for it, and that's what we're aiming to do.
Hello, everyone. My name is Gary Blanchard. I am a geriatrician and the geriatrics medical director at St. Vincent Hospital in Worcester, and we are thrilled to be here as a first-time coalition member. So, on behalf of our wonderful and wonderfully interdisciplinary Patient Wishes Committee at the hospital, I wanted to very briefly share some of what we've been up to that we feel dovetails with the coalition's initiatives. First of all, we have simply christened a palliative care service line under local hospital control. That sounds, in listening to all the other speakers, like a relatively modest accomplishment. But I would say, from my own humble perspective, to be able to disseminate the work that we're all doing here at the community hospital level, that goes a tremendous way. And our community hospital in particular has, let's say, not always been hospitable to some of the goals of palliative care. So we're very excited to begin that journey. We have also begun to create, develop, implement, and evaluate a palliative care communication series that we're trying to reach every discipline in our hospital, and have that focus on giving people the words and the comfort and the knowledge to be able to advocate and initiate conversations related to advanced care planning and goals of care. The foundation really of what we're trying to do, the anchor of what we're trying to do, is our Patient Wishes Committee, which has the support and membership of our hospital leadership, nursing leadership, physician involvement, chief medical resident, case management, and certainly input from patients and families as well. And what we've really tried to do is develop a fun, interactive curriculum where our goals are in the next 1 to 2 years, have more than half of all of the nurses, PCAs, CNAs, case managers, residents, volunteers, therapists, everyone that can potentially interact with a patient to be able to give them that course and those tools to try to do a role play. Have the resident, have the nurse, have the PCA be equal partners in a role play with a quote-unquote difficult family member, a challenging conversation, to give each other feedback really in an interdisciplinary manner. It's wonderfully heartening to see oftentimes how that plays out, and to have the residents and some of the other learners do conversation project starter kits with each other. We're really filled with hope about the future. And finally, I would just say that we really are in our embryonic stages here at St. Vincent Hospital, but 2 observations that I have made, that I have found, is that there really is a difference between teaching this in an interdisciplinary manner as opposed to a multidisciplinary manner. Interdisciplinary, really having the residents side by side with the nurse, side by side with the aide, and realize that we all struggle with this at times, and this is anxiety-provoking for all of us, but to try to do it together. And finally, that truly to have culture change at an institution, culture change really has to be at the most local of levels. So we really try to drill down to each nursing unit, each shift, each bedside nurse, so that eventually the folks who have gone through this course that we've come up with, we can ensure that the nursing directors and the nurses and the aides, that there's always someone there who can advocate with this in mind for each shift. So thank you very much for the opportunity today.
Good afternoon. My name is Aline Risseteau, and it's a tremendous honor to say a few words on behalf of my colleagues from Hebrew Senior Life, an organization that supports the lives of 3,500 older adults, the 3 superstars that you heard from this afternoon being in the room, and that employs 2,500 employees, 20 of whom are in the room today. Aligning the delivery of care with values and preferences is really something that I consider to be part of the DNA of our organization. We like to call it resident-directed care. What the coalition has really allowed us to do is to shine the spotlight on that core part of our mission, raise the bar, and really fuel our passion even more than it had been, and it's been a tremendous gift. Because of the size of our organization and the different services that we provide, we decided to start and launch 9 different pilots within our organization, 1 per entity. Each of the pilots would be dedicated to following the roadmap of the coalition, aligning with its own goals, impacting both residents' lives, patients' lives, family members, and staff members, with the ultimate goal of creating some Hebrew Senior Life best practices by the end of the year. So a few things that we've learned along the journey are those that have stood out to me most. One is the power of grassroots efforts. It's been absolutely amazing to have the opportunity in our organization to bring together all these multidisciplinary professionals in a brand new way, committed to fuel the passion behind this project. We've also learned the importance of leadership buy-in and how to really gain support from our leadership to give us the tools and the resources to carry forth the passion for this project. And then I'm going to steal a quote from Dr. Lachlan Farrow, who's really become a mentor and a fabulous friend in this project, is how to normalize the conversation, how to saturate all of our communities, all of our service lines with all kinds of tidbits of opportunities to think about what matters most, to think about how to live your best life every single day, and not just think about end of life. How do we engage our staff members as they become employees of our organization to actually define what matters most to them? So lastly, our organization lives by what we call cultural beliefs, and we've recently updated our cultural beliefs, and one of our new beliefs is ask what matters. And so by reminding all of ourselves every single day to ask that question and not to forget that we should not assume that we know what people know is important to them, but really be reminded to ask the question. Thank you.
Atul, do you have a final reflection as we wrap up?
I think what the last group brings home is the theme of teaching. And having walked this journey for the last few months with Harris about bringing the medical deans on board and then making it come alive, teaching is complicated because we're starting in a place where, we're trying to assure that everybody has these conversations, and we don't even have the teachers who know how to make sure that it happens. And so these efforts end up being, number one, what are the teaching resources out there? And we're lucky. There are a lot of teaching resources out there and curricular materials, whether it's IHI's work with the Conversation Project or other people's materials, Honoring Choices, the Serious Illness Care Program, and so on. Second is that you need to have a teacher development program, a way of developing the teachers. And that means sending people to courses and workshops or going and visiting interesting places and learning along the way. And I think that we're just learning how to train all the trainers that can be out there in this community. And I expect we'll have even better materials for doing that come a year from now.
Well, what a day. On behalf of Atul and Ellen and Andrew and I want to say thank you. And in keeping with your philosophy of a story, I'll end with a very brief story before you head back. Andrew started the day by talking about the complications of the current healthcare environment nationally and how the political environment is a struggle for us. I live in that world part-time, and I also find great hope from being in this world. But recently I was in Washington, D.C. at a bipartisan congressional retreat, and I have to say, when I left the meeting, I was feeling more like Andrew described this morning than I do feel like I am feeling this afternoon. It was pretty rancorous, and people were fighting for their position, and it was, one of those meetings that you leave and you don't feel like you're making progress. I get in the taxi to drive to the airport, and the taxi left, and I was feeling all the tension of the current political environment. And I looked out the window, and it was a beautiful day. And I said to the taxi driver, "It's a beautiful day, isn't it?" And he said, "Yes, it is." And then he turned around and he said, "No, it's not." And I said, "Why not?" And he said, "I just got a phone call that my wife's best friend died, that she and this woman had been best friends since they were 2. They lived next to each other. They had gone all through kindergarten, all through grade school, high school, and college together. And when they each got married, they deliberately bought houses that were 3 houses apart. They had been best friends forever." And he found out that she had died, the best friend. And I said, "How's your wife?" And he said, "She doesn't know." And so I said, this was noontime. I said, "How are you going to tell her?" And he said, "Well, when I get home from work, I'll have dinner, and then I'll talk to her." And I said, "What time do you get home from work?" And he said, 11 o'clock tonight. And I said, "No, I think your wife is going to hear about this beforehand." And he said, "I don't know what to say." I said, "Have you ever spoken to your wife about dying?" And he said, "No, we've never talked." So I said, "Pull over." I did. And I said, "I'm going to get in the front seat, and by the time we get to the airport, maybe we'll have come up with some ideas." So he was so afraid to talk about this that he said, I can text her. I said, "No, this won't work." And so we talked the whole way to the airport, and finally when we got to the airport, I said, "How about this? What if you call your wife on the phone when we get to the airport and you say, 'Love lasts forever, but life doesn't, and I have to tell you something.'" And he said, "I think I can say that." So the rest of the way to the airport, he kept saying, "Love lasts forever, but life doesn't, and I have to tell you something." And we got to the airport, he went in and made the call, came out, gave me a huge big hug, and I can tell you that I left the cab much in a different place than I left the meeting. I left the cab feeling like when we are able to talk, when we're able to share, when we're able to focus on what seems like such difficult conversations, that oftentimes we feel peace and joy. And so I would encourage you, maybe even tonight, to have a little conversation over dinner, to raise something like this that you might feel is a challenge, because together I can guarantee you, you will find a joy, a peace, a sense of accomplishment when you do have the courage to break the ice, and you'll make it a great day. So thank you all. Well before next year, you're going to hear from us. You're going to get newsletters. You're going to get stories and encouragement, more videos. And together, we can change the world. Thank you.